trying. There is some issue with the password. So.
Hello. Good evening, Dr. Kaul.
I think, Dr. Nishkarsh, we are live on YouTube now. You may please proceed.
Yes. Good evening, everyone. So today I invite you all for another academic feast by RSACP. So we'll be taking the exam-oriented webinars for postgraduates forward again today. So we have, I welcome President RSACP, Dr. Indrani, President-elect Dr. Naveen Malhotra, Vice President Dr. Anju, Secretary Dr. Vishal, and all the GC members. I also welcome all the chairpersons who are esteemed faculty and have taught most of us around, and the delegates who will be attending the webinar. Sir, Dr. Indrani is probably not logged in. Dr. Naveen, you want to give a welcome?
She'll be joining soon. She's already there. She'll be joining soon.
Yes, sir. So Vishal, Dr. Vishal, you can do some.
Good evening, respected patron Dr. Tejke Kaul sir, Dr. Naveen Malhotra, President-elect sir, and all the GC members. I welcome all the esteemed faculty for the part 2 of this anesthesia equipments related webinar. I could not be part of the first part of this webinar due to sad demise of fellow anesthesiologist in this post-COVID phase. This COVID has taken big toll on all of our lives, and post-COVID is equally bad, I guess, in some cases. Postgraduate exams are around the corner, and we all understand that PG students have worked very hard and very bravely in this pandemic. I wish all the best to the exam-going budding anesthesiologists, and I would like to give my best wishes to all the examiners. We have on board some very senior examiners, Dr. Jayashree ma'am, we have Dr. Ashok Saxena sir, Dr. J.S. Dali sir, Dr. Manisha ma'am, Dr. Indrani ma'am, Dr. Naveen Malhotra sir. I am sure the students will benefit a lot from the wisdom and experience of the faculty. I wish all the fellow doctors to stay safe, follow the COVID safety protocols, and all the very best to the team Delhi for this aptly timed webinar, which will be beneficial to not only the exam going students, but also to the practicing anesthesiologists. Thank you very much, and over to you, Dr. Nishkarsh.
Thank you, Dr. Vishal. Dr. Indrani is here. Good evening, ma'am. So you want to give the welcome address for the webinar today before we start? Ma'am, you are mute.
Good evening, everybody. In continuation with the webinar for the postgraduates, we are having the second part of the webinar today, and I'm sure it must be very, very helpful to all of you. Last week we had a tremendous response, and I'm sure this response is going to continue today also. And we have some very important aspects of the Viva, like AMBU bag, and they may show you a CVP line, central line, and ask you some details on CVP, and anesthesia safety checklist, double lumen tubes, BIS monitoring, neuromuscular monitoring. All these are important aspects of your table viva, and I'm sure even if you know the few nuances, if you pick up today, you will crack your viva very well. So congratulations, Delhi, and let us continue without any delay. Thank you very much, and long live RSACP.
Thank you, ma'am. Thank you, ma'am, for the kind words and giving opportunity to Delhi team for the webinar. So I'll first introduce the chairperson. So for today, we have a great team of chairpersons, and they are very senior anesthesiologists, and many of them have taught most of us around. So first, I'll introduce Dr. Jayashree Sood. She is presently a chairperson in Department of Anesthesiology, Pain and Perioperative Medicine at Sir Gangaram Hospital, and she is also part of the board of the Sir Gangaram Hospital. It is difficult to sum up the CV in a short time, and she has a lot of accolades to her credit, and published widely and has 5 books to her name, and she has been part of many orations and many conferences. Presently also CEO of Indian College of Anesthesiologists. We welcome you, ma'am.
Thank you. Thank you, Nishkarsh.
Then we have Dr. Ashok Kumar Saxena. All of us know Dr. Dali and Dr. Ashok Kumar Saxena. Dr. Dali is ex-professor, director professor, Maulana Azad Medical College. I have been lucky to be taught by him, and he has been very meticulous anesthesiologist. Somehow his slide is somehow not there for some reason, and he has many publications to his credit. He has been known for few topics lately, and oxygen therapy is one of his pet topics. And in COVID era, all of us know oxygen therapy is the only therapy which we can give to the patients. And we welcome you, sir. Then I also invite Dr. Ashok Kumar Saxena, professor and head of Department Anesthesiology, Critical Care and Pain Medicine at GTB Hospital. He has been associated with pain for long, and one of the pillars of pain medicine in India. He's been ex-editor of Indian Journal of Pain, has many published articles on pain and anesthesia, and was part of many committees regarding the guidelines for pain management as well. We welcome you, sir. Then we have one more chairperson, Dr. Monisha Agarwal. She is also from my college, Maulana Azad Medical College, and she has been very meticulous in teaching all of us. A lot of importance has, whatever we had today is because of all the faculty from Maulana Azad Medical College, including Dr. Monisha. She has special interests in fibro-optic bronchoscopy and difficult airway management, and has been lead faculty for teaching basic life support, adult cardiac life support, and airway management in MAMC. Thank you, ma'am, for being here. And now I'll request Dr. Jayashree to start the webinar series. We have about 90 participants as of now, and I'm sure we'll be gradually inching up. Probably the services have been started at most hospitals, and all of us have been rushing to start the webinar. So maybe another some time we have more people who join in here. Dr. Jayashree, please, you can start now.
Thank you, Nishkarsh. And as we heard that this is our second webinar, second series of the exam-oriented equipment webinar. And today again, we have very, very important lectures. And the first one, to start off with, we have a lecture on the ambu bag, which sounds so basic, so important, on the table for your viva, and there could be a short note as well. So for this lecture, we have a very eminent speaker, Dr. Manpreet Singh. You all know him very well. He has got several qualifications. He's an MD, FCCP, FACE, FIMSA, and MAMS. He is the professor at the Government Medical College and Hospital, Chandigarh. His areas of interest are airway management, trauma, resuscitation, and emergency medicine. He has several, more than 132 national and international publications. He's a member of more than 15 national and international societies, reviewer of whole lot of journals, 74 chapters, and he has conducted various workshops. So you can well imagine he's the right person for this lecture. Dr. Manpreet, could we please hear your lecture?
Thank you, ma'am. Dr. Nishkarsh, can you talk to Dr. Rakesh for my video? I have already sent you yesterday.
Rakesh, please share the video.
It is always nice with talking to our teachers on this platform when they introduce me, and I feel proud not because of me, but because of my teachers and all the seniors who have taught me. Dr. Ashok Saxena was my teacher in GTB hospital, and Dr. Jayashri Su, Dr. Dali, yesterday he was also here to come. And I'm thankful to these people who have taught me in one way or the other. And I have learned a lot from Dr. Saxena in GTB hospital, and I've worked with him in many operation theaters also. So I think Dr. Rakesh will be sharing my video. Otherwise, I could have sent the spoken on the live, whatever they say. I'm thankful to the organizers, Dr. Naveen Malhotra, and whole team of RSACP. They have given me the opportunity to speak on this. And
Dr. Rakesh.
सर आपके पास लिंक है तो उससे फोन नहीं लग रहा राकेश का, सो मैं यहाँ से प्ले कर दूंगा फिर. और
no, it was not link, मैं direct video ही भेजा था मैंने उनको.
Sir, if you have the video in your laptop, you can start your screen
Also
sharing.
play,
Now,
yeah.
Okay,
You
let
can
me
also
see.
play from your
laptop.
Okay, I can share the screen then, है ना?
हाँ, आप स्क्रीन शेयर कर लो.
Let me see now.
For everybody to know, we shall be having all the lectures and then question answers at the end of all the lectures.
I think now the screen is visible.
Yes sir, visible.
Yes, it is visible.
Let me try if it works. Is it working?
Yes,
You were able to see that or not? And listen a voice.
नहीं, voice नहीं आ रहा.
Voice नहीं आ रहा ना. That was the only thing I was thinking. Or what I can do is I can start live. That is more.
That we can do, sir.
I can do.
We can do live. Sir.
I can do live. That is.
Yeah. I think you start off. That will be good.
Okay, just hold on फिर then. मैं इसको बंद करता हूँ.
आज सब्जी नहीं खाई, जरा सी सब्जी ली सुबह, बहुत सी
परसों ले गाड़ी ਇੱਥੇ ਹੀ ਖੜੀ ਹੈ ਉਹ ਹੁੰਦਾ ਨਾ 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 मतलब एंटर नहीं हाँ अंदर नहीं जाना बाहर ही नजर आ जाएगी.
Now the screen is visible. My screen is visible.
Sir,
It's your introductory slide. We
Yeah,
can see.
yeah. So
Yeah,
I'll start
it's-
now. So
yeah.
I'm Manpreet Singh. There are certain glitches of this computer, but let's go on with the show. And my topic is EMBU bag, which is also called as artificial mechanical breathing unit or bag valve mask assembly. And it's most important topic. What is important is that it is always asked for the post graduations in the post graduation on the table, and it is one way or the other. It is always kept in the on the table, and then the post graduation in the postgraduates they often fumble with the basic concepts of this EMBU bag. This is the EMBU bag you can all see on the screen. And let me ask, what are the parts of EMBU? So it has to be explained like this. It has a self-expanding bag with a non-rebreathing valve, a facility for the admixture of oxygen, a bag inlet valve, and there are the optional components which are pressure limiting device and oxygen enrichment device and PEEP valve and the mechanism for scavenging and the other things. Let us know about EMBU bag. A brief history of 2 slides. Dr. Holger Hesse in 1953, he was a Danish engineer with Professor Henning Reuben. They both met in one time in 1953, and they designed a breathing apparatus to improve the survival chances of patients in emergencies outside the hospital. And the word EMBU was coined from ambulance, and the reference to bagging was coined by the rescue workers who were there during those times in the ambulance. And Hesse and Reuben named the company EMBU, and it is still operating, which we are using nowadays. In 1956, the EMBU ventilation bag was first words self-inflating resuscitator was invented, and it was used. It is a handheld device commonly used to provide the positive pressure ventilation to patients who are not breathing or inadequately breathing. And if you see, it is used in resuscitation equipment in remote areas and the camps. It is a part of resuscitation kits and in the crash cart. You can see the parts, that is bag, valve, and mask assembly. It is broadly termed as like this. And in the diagram on the slide, you can see there is a valve assembly, then tubing is also there, and reservoir bag, which are the accessory things. I'll discuss the valve assembly first, which is the most important in this. The valves, if you see on the slide, it has a valve body assembly, which has the associated internal parts, including one or the two movable things, which opens or shuts or partially obstruct in one part or the other. Then there is a valve seat. It is a surface, usually annular one, with an opening which may be partially or completely obstructed. Then there is a patient port, and there is an exhalation port. These are the parts of the valve. What do you know about the non-rebreathing valve? If you see that, it is a directional control valve. It is a one-way one, and most rebreathing valves are the T-shaped. It has an inspiratory, expiratory parts, and then the patient's end is a 15 to 22 millimeter of coaxial fitting. It should be transparent so that the internal mechanism of movement can be observed easily. And what are the types of the valves? There are different types of the valves which can be asked on the table. That it has a flap valve, there is a fish mouth valve. In flap valve, there is a flexible material flap which is present in the apparatus. And then there is a fish mouth valve, which is usually we are seeing day in, day out in the EMBU bags we are using. And it has a two flaps which are approximated at the midpoint. Then there is a disc valve, that is a spring loaded, and a mushroom valve, and there is a diaphragmatic valve. Let us discuss about the flap valve mechanism. If you see on the slide, it is closed in the first ones. You can see here in follow my arrow, if you can follow that it is closed normally, but when it is open, when the air is pushed inside, then what happens is the flap goes back and the air goes into the patient. And similarly, there can be two-sided flaps, there can be two flaps valves, in which there is a peripheral flap valve and there can be central flap valve. So during inhalational, the central one opens and the air goes inside. And during the expiration, what happens is the central flap goes on the back seat, on the center seat, and then the peripheral ones are opened, and that's why they cause the exhalation. Similarly, there is a spring disc valve which has a spring with a disc, and disc sits on the in the midline, and whenever there is a inhalation, you can see that in this follow this arrow, when the air goes in, what happens is the disc moves on the spring on the back, and the air goes inside to the patient. And similarly, when the expiration is there, that comes back, and from the sides, the exhalation occurs. This is a fish mouth valve. You can see that here there are two flaps which are together joined in the midline, and then the air, when the air is pushed in from the bag, when you press the bag, this fish mouth valve opens and the air goes in. Then we have the Rubin valve. It is an individual non-rebreathing valve. You can see that this valve is most commonly used earlier. It has a bobbin in the center with the spring, and what happens is when the fresh gas flow goes in, this bobbin moves back and spring moves back, and the air goes inside to the patient. This is the inspiratory phase. When there is an expiratory phase, when the patient exhales, this bobbin comes back, spring is back, and then from sides it exhales. So this is the Rubin valve. And you know, the Rubin valve was described by Rubin in 1955. Then we have the Ambu E valve, which has the leaflets in between. Then we have Ambu E valve functioning. If you see on the slide, it is similar to what I have described in earlier valves. Then we have Ambu Mark 3 valve, which is used in the battlefields. People use this type of Ambu bags. Then we have Ambu single shutter valve, where the expiration and inspiration occur with the single shutter only. And then we have the lateral pattern valve. Then how do you classify these valves? The question may come. It is based on the mechanical characteristics like presence or absence of spring, rubber flat, or there can be a knife edge, etc. Or this is based on the functional classification, like whether it can be used in spontaneous ones, or it can be used in controlled one, or both. In the spontaneous one, what happens is when the inspiration is there, during inspiration, negative pressure closes the expiratory valve, and during expiration, we give the positive pressure, it opens the expiratory valve, and this is how it functions. In controlled ventilation, inspiration is a positive pressure because the patient is in the controlled one, and it opens the positive pressure, opens the inlet valve and closes during the exhalation port. And there are certain valves which are designed for both spontaneous and controlled ventilation. These are called as automatic non-rebreathing valves. And in these valves, the exhalation port is closed and inspiratory port is open, whether it is spontaneous or controlled. Then there are certain other classification also. This I have taken from the Anaesthesia 2017, a fresh article just 4 years back, which has been there. And they have given this classification according to the inflation valves according to the method of operation. It is a method of exit valve. If you see that, it can be closing or opening, and it also, all those valves which I have already discussed, these are included in this. It is just to see that which one is the opening one and which one is the closing one. This table you can see there in Anaesthesia 2017. And then what are the advantages of Ambu bag? When it will be asked on the table, what are the advantages on the Ambu bag? You have to answer like this. It's a lightweight, compact, mobile, inexpensive, simple. Then carbon dioxide absorption system is avoided in this. And the most important thing is the mechanical device. So you don't require any electricity. It can be used at any place. Less dead space is there, less resistance, composition of delivered and inspired gas is same, and better feel of lungs can be there when you press these bags. What are the disadvantages? Disadvantages are large volumes of inspired mixture can be given, and it may cause the OT pollution. There can be the minute ventilation matching is very difficult to maintain. If noisy and sticky valves are there, then rebreathing can occur. Sometimes 2 hands may be required to ventilate. Cleaning, sterilization is little cumbersome. You have to open the valves and then you have to clean those valves. Otherwise, it will cause there can be stickiness of these valves. Increased resistance with higher flows and some difficulty to use with scavenging system. There is no standardization among the valves. This embu bag, internally you can see this is the picture which is showing everything of the embu bag inside. Everything is given. This is a bag with the valves and how the oxygen delivery system is attached to it. What are the characteristics of the self-inflating bag? It is inflated in this resting stage. Some bags collapse like an accordion for the storage. During exhalation, the bag expands. And if the volume of oxygen from the delivery source is inadequate to fill the bag, then it covers from the rest of the things, it covers from the air. What are the pressure limiting devices in this? Sometimes PEEP is also given through this. There are certain extra devices which are attached, and it is a spring loaded disc and magnetic device which is attached there. You can see here, this is the extra one which is attached, and maximum pressure depends on the size of the hole and how the bag is compressed. For adults, it is less than, pressure is maintained less than 60 centimeter of water, and infants and child, it is less than 45 centimeter. There are oxygen enrichment devices which are attached behind, and it can be open ones like the corrugated tube which is attached sometimes, or there can be closed ones like a bag which is attached behind, which takes out the extra oxygen which is delivered during the procedure. The bag is with different sizes. It is manufactured with the adult of 1600 ml, then 500 ml. It ranges from 240 to 1600 ml. With the reservoir bag which is attached behind, it ranges from 600 to the 2600 ml. The functional analysis, you can see that minute ventilation is tidal volume and respiratory rate, and it depends not only on the resuscitator performance but also the operator skill. How do you operate it? That is most important. Tidal volume delivered when the bag is compressed will vary with the size of the user hand, and whether one hand is used or the two hands are used, it depends on that. Then respiratory rate is important, when the how much fast you are doing and how much re-expansion of the bag is there. That is also dependent on the how the respiratory rate will be dependent on that. The important thing is the inspired oxygen concentration can vary from 21% to the 100% and should deliver at least 40% when connected to an oxygen source supplying not more than 15 liters per minute. If the volume of the reservoir, this is to be noted, if the volume of the reservoir is greater than the volume of the bag and the oxygen flow is greater than the minute volume, the delivered oxygen concentration may reach approximately 100%. So you can give 100% oxygen also by changing the configuration of the embu bag. And how do you check embu bag? Visually inspected for signs of wears and tears, should be checked for any leaks, visible leaks, or the patient port should be occluded. If you see this diagram, I have given this. If you see this, you can occlude the patient end first, and then after that, what happens is the bag is squeezed and the pressure should be built up rapidly to the, so that the if there is no more compression which is occurred, then this means the valve is functioning. But if it is fully compressed after occluding also, this means there is some leak in the fish mouth valve which is present there. Then the distal valve is also to be seen. You occlude from behind the embu, from behind the embu, both the ports of oxygen and the this bag refill valve area. You occlude that with your hand and then you squeeze it. If you are not able to squeeze it, this means the air cannot be sucked from there, and therefore there is no leak in the valve. So this is how you have to check embu always. The embu can come in different companies manufacture in different ways, different materials. There can be double covering embu bags also. Then there can be single covering. Indications, you all know what are the indications and contraindications of use of embu bag are hypercapnic, respiratory failure, hypoxic failure. Then there can be altered mental status with inability to protect the airway. Then sometimes you can use the positive pressure ventilation, that ventilation to cardiac arrest, respiratory arrest. In the wards, you can use in the fields, you can use in the camps, disasters, battlefields. It is an easy to use device, but with the right technique. You contraindications, sometimes there can be total upper airway obstruction, do not use it. And there can be increased risk of aspiration sometimes, then do not use it. Then what are the complications? The complications of use are related usually to the overinflating or over pressurizing the bag. What happens is it may cause air to inflate the stomach, may cause the regurgitation. Then there can be aspiration pneumonia also. Then lung injuries occur may due to the overstretching, may cause volutrauma, or there can be pressurization and cause the barotrauma. It may cause pneumothorax. Rarely reported case reports are there which have shown the air embolism with the over pressurizing and air in the vessels or the increase in the pulmonary arteries which has gone to the heart also. So there can be claustrophobia also. Sometimes patients may feel that there is a claustrophobia. How to use the technique? CE technique is the well-formed technique. You all know that at the head end, the patient rescuer should be there, and then patient's position should be sniffing. Use the jaw thrust if cervical spine injury is there. Do not tilt the head if there is a cervical spine injury. Place the mask over the patient's victim. Make the C with your thumb and the index finger as shown in the diagram. And then you can do the compression with C, and rest of the three fingers will elevate the jaw. That is called as elevation. So CE technique is very important. Tilt the head, give ventilation, see the visible chest rise. Before that, if you are not able to do the ventilation with one hand, use two hands holding the mask. And if you are not able to do that, use your basic concepts of oropharyngeal and nasopharyngeal airway if required, and see the airway assessment detail before also whenever you are using these type of systems. In edentulous patients, there is a difficulty in holding the mask in these patients. The leak can be there from sides, so you hold the mask there and then put the gauze pieces from sides and make a tight seal so that you can improve the seal and do the mask ventilation through the embu bag. So then what are the changes? Last two slides. What are the changes that are adopted in the technique of ventilation during COVID pandemic? Always use bacterial filter or the viral filter, which is attached to the inspiratory port of the bag wall mask assembly. Then manually ventilating a patient with the endotracheal tube or tracheostomy tube is acceptable. Use the viral filter right in the place. Then HME filter does not give the 100% coverage to the virals. So what you do is better avoid this. If you have the viral filter, use the viral filter. If you do not have, then you can do with the HME filters. Staff should wear the PPEs and all their N95 and all the precautions which are to be taken care of while doing the handling the airway in the patients. So do not take it very lightly, because COVID pandemic, you all know it's a very dreadful disease. So how to sterilize the embu bag now? Usually it is a disposable, sometimes we have the reusable ones, and autoclave is the best one at 134 degrees. And otherwise you can sterilize the embu bag with the glutaraldehyde 2% at is an appropriately high level disinfectant, and it should be kept in the glutaraldehyde for 20 minutes. Then only it is sterilized. So valves should be opened. Remember this, the valve should be opened and dried completely before reassembling them after the sterilization. And before sterilization, you have to open the valves, otherwise it is not completely sterilized. So reassemble again and again, do the pre-use check of all the valves, whether it is rightly fitted or not. Key points to ponder are: embu is a resuscitation equipment. Always check the inventory. Pre-use check is important. Always check embu bag always before use, because it is kept in the inventory always, and then sometimes cardiac arrest occurs. You use that, and it is never checked before, and don't know how many days before it was opened. So always do the checking of the embu. And then sterilization of embu is very important. Check after sterilization also. Learn the right techniques and holding of mask with the right techniques always, because you should know how to hold the mask. You should know how to do the embu bag ventilation. COVID protocol is to be followed in pandemics. You cannot omit those protocols in embu bag. Thanks and best of luck for the exams. Thank you so much.
Thank you, Manpreet. Thank you, and we'll take the question and answers at the end of all the lectures. Thank you very much.
Thank you.
Dr. Dali, could you introduce the next speaker, please?
सर आपकी आवाज नहीं आ रही.
Is he there? He's there, Nishkarsh?
Ma'am, he's there.
Nishkarsh?
Ma'am,
Okay.
he's there. He's there.
Yes, ma'am, he's very much there.
Okay. Otherwise, Ashok can introduce the next one and Dr. Dali the third one.
Hello. Am I audible now?
Yes, Dr.
Yes,
Dali,
sir,
we
you're
can
audible.
hear you. Hanji.
Can you hear me?
Yes, yes.
Okay. Good afternoon, everybody. Sorry for the little trouble over here. I congratulate the organizers for this such an endeavor in this difficult times for our postgraduates. And I know that their academics are getting a lot of setback, and such an endeavor in this moment is a very, very admirable thing. And I am thankful also for them to include me in this academic feast in this evening. And the next speaker is Dr. Indra Malik, and she is assistant professor at PGI Rohtak, and she is fellow of Indian Association of Cardiovascular Thoracic Anesthesiologists. She has several publications in the National and International Journal and chapters in the book. And if I'm not mistaken, Dr. Indra Malik was probably working near our institution in Jeevpant. I think she is the same Indra Malik, and probably she was there at the time of UPNC interview when I was there as an expert member. So I welcome her and request her to present her talk. Dr. Indra Malik, please.
So her talk is recorded, so I'm just playing, starting the recording.
Yes, she will be speaking on the CVP monitoring. CVP monitoring.
Yes, sir.
We can't hear. So I need it.
For giving me the opportunity to participate in this webinar. Starting right away with central venous catheters. In your table viva, you may be asked, like, what is this equipment? So your answer should be, it is a central venous catheter. Now, central venous catheters may be classified according to the number of lumens they have, that is single lumen, double lumen, triple lumen, 4 and 5 lumen. They may also be classified according to the technique of insertion, that is Sendinger technique, which is guide wire based, and non-Sendinger, which is basically a catheter over needle technique. Now, the normal CVP waveform, it has an A wave, a C wave, an X descent, a V wave, and a Y descent. What do these different waveforms signify? Now, the A wave comes due to atrial contraction, which happens at the end of the diastole. C wave, which occurs due to closure and bulging of the tricuspid valve into the right atrium. The V wave occurs due to passive atrial filling during ventricular systole. The X descent is due to pulling away of the tricuspid valve from the right atrium during RV systole, and X descent is due to the opening, and Y descent is due to opening of the tricuspid valve. Now, these waves are of diagnostic value too. Like an absence A wave would signify atrial fibrillation. A Canon A wave or a large size A wave signifies tricuspid valve stenosis, right ventricular hypertrophy, pulmonary stenosis, or pulmonary artery hypertension. Large V waves may be found in right ventricular failure. Now, there is an M pattern where there is a prominent A and B wave. External jugular vein, then subclavian vein, external jugular veins, femoral veins, and antecubital veins. So, internal jugular venous cannulation for the purpose of central venous pressure measurement or central venous cannulation was first described by English and colleagues in 1969. The right IJV is preferred over the left because it has a straighter force towards the right atrium. Now, there are three different approaches of cannulating the internal jugular vein: anterior, middle, and posterior approaches. So the middle approach is preferred the most. Here, the IJV is punctured at the apex of the triangle, which is formed by the clavicle. The clavicle forms the base of the triangle, and the two sides of the triangle are formed by the medial and the lateral heads of the sternocleidomastoid muscle. Now, the patient is placed in 10 to 20 degrees Trendelenburg position with the head turned to the left side when the right IJV is being cannulated. Sometimes in obese or short-necked individual, a shoulder roll may be placed horizontally under the shoulder to extend the neck. Now, in the anterior approach, the vein is punctured at the medial border of the sternocleidomastoid at the level of laryngeal cartilage. In the posterior approach, the IJV is punctured at the intersection of the sternocleidomastoid with the external jugular vein. What are the advantages of cannulating the internal jugular vein? So it has a high success rate, first and foremost. The access is very easy from the head end of the operation table, so it is very convenient for an anesthesiologist. Less chances of pneumothorax are there with this route, but it has some disadvantages as well. Risk of carotid puncture is always there. So in case of carotid puncture, if the puncture happens with a wide pore needle, then we should compress that point for at least 2 to 3 minutes before taking the next attempt in order to prevent hematoma formation, which will make further cannulation difficult because there is a very small space in the neck. So if there is a hematoma is formed, all the structures will get displaced, and it will also exert pressure on the different structures in the neck. Then the IJV may be difficult to locate in short, thick neck and obese individuals. Here, ultrasound-guided cannulation may be of immense use. Now, the subclavian vein. The subclavian also has two different approaches, that is supraclavicular and intraclavicular, out of which the intraclavicular approach is used more commonly. The point of insertion is 1 centimeter below the midpoint of the clavicle, directed towards the suprasternal notch under the posterior surface of the clavicle. Here again, the patient is placed in slight Trendelenburg position with the head turned to the opposite side. A roll will be placed under the back between the scapulae, and the ipsilateral arm is fully adducted. The advantages of this route are that it is easy to maintain for a longer period of time, especially in ICU setup, and it may be the cannulation site of choice in neck surgeries as in carotid surgery. The disadvantages of the subclavian route are that the risk of pneumothorax is much higher than it is in IJV or EJV routes. Subclavian artery puncture may happen, and it is even more difficult to compress the subclavian artery once it has been punctured, which can lead to a big hematoma formation. Misplaced catheter tip is a complication which occurs very commonly in this route, and we would find the catheter commonly displaced into the ipsilateral IJV. Then aortic injury, cardiac tamponade, mediastinal hematoma, hemothorax, all these things have been reported with the subclavian route of cannulation. The femoral vein. It is a less commonly preferred site as it is prone to get infected easily. And this practice advisory in 2011 by O'Grady and et al. They specifically said that it is a class 1 recommendation with level of evidence A, that this site is very prone to get infected and should be avoided for routine central venous cannulation. The femoral vein is located just medial to the femoral artery pulsation. It is punctured 1 to 2 centimeters below the inguinal ligament, and it can be the preferred site of cannulation in certain cases, like the Glenn shunt in pediatric cardiac surgery, which is a cavopulmonary shunt. So in case there is a surgery on the superior vena cava itself, then we cannot cannulate either the IJV or the subclavian, as is also the case in SPC obstruction. So in that case, the femoral vein comes into play. The advantages are that it is easy to cannulate, especially in the emergency room scenario, and it can be maintained for a longer period of time. Disadvantages, as we discussed, is infection. Of course, there is femoral artery puncture and hematoma also, which can occur. The external jugular vein, this is visible externally in the neck and lies over the lateral head of the sternocleidomastoid. The success rate may be slightly lower because it has a tortuous path, so it is difficult to manipulate the guide wire a little bit. But the advantages are that puncture of deeper structures of the neck is avoided. Now, the antecubital veins. The cephalic and basilic veins can also be used to access the central venous system. So separate catheters are available to cannulate these veins, which are available in 45 to 70 centimeters length. Commonly accessed from the right side with the patient in supine position, ipsilateral arm fully abducted in this case. And they can be used in cases where neck access is unavailable and also in ICU setup. Now this table shows the different routes of cannulation which I used and the ideal length of the central venous catheter which should be inserted from each of these routes. Now, a word about ultrasound-guided central venous cannulation. We have heard a lot about the benefits of the ultrasound-guided cannulation. So, if we see the first benefit is that there is a higher first attempt success rate and fewer total number of attempts. Useful in difficult neck anatomy, there are fewer complications when we use an ultrasound. The ultrasound also demonstrates vessel patency and anatomical variants, if any, and in most hospitals, it is now easily accessible. But there are some concerns as well with ultrasound-guided cannulation. The first of which is training of personnel. So there is a long learning curve, and it requires a person to do a number of procedures before they become an expert in performing ultrasound-guided cannulation. In addition, there is lack of observance of surface anatomy, so it becomes too much dependence on technology. And over time, as we use ultrasound only for cannulation, there can be potential loss of the expertise in using the landmark technique for cannulation, which can again become a difficulty, especially in the emergency room scenario, where the ultrasound may not always be available. And the situation may be difficult. The patient may be having a low blood pressure or maybe having a difficult neck anatomy. And most of the time, the personnel which are available will also be of the junior level. So it is also very important to retain the skills using the landmark technique to cannulate central venous veins. So now let's take a look at the different type of catheters which are available, which we have. So this is a single lumen central venous catheter, Seldinger type. We can see there is a needle, then there is a guide wire, dilator, and catheter. So you can appreciate that the length of the guide wire will always be greater than the length of the catheter, and it will be at least 1.5 to 2 times the length of the catheter. This is a double lumen central venous catheter. This is a triple lumen central venous catheter, which we use most commonly in our practice. All these catheters are made of polyurethane material, and they may be available in Seldinger and non-Seldinger types. Also in heparin coated and antibiotic coated types, which can be used for a longer period of time. This is an antimicrobial coated central venous catheter, triple lumen. This is a silver impregnated 4 lumen central venous catheter. These catheters can last for a longer period of time. This is a 5 lumen central venous catheter. So the greater the number of lumens, the greater is the chance for infection or progression as well. This is an antimicrobial coated 5 lumen central venous catheter. Now this is a peripherally inserted central venous catheter, which I told you can be used to cannulate the cephalic and basilic veins and access the central venous system from the peripheral vein. Now some of the special central venous catheters, which I mentioned earlier, heparin coated ones. So they can be an effective method to prevent catheter-related bloodstream infections. There may be slight increase in the risk of bleeding, but heparin-induced thrombocytopenia has not been observed with their use. Antibiotic-coated central venous catheters, they are useful in avoiding nosocomial infections, commonly associated with long-term insertion of these catheters. They can be pre-treated with tridodecyl methylammonium chloride and are bonded with vancomycin prior to insertion. Especially useful in patients who require prolonged ICU stay. Antimicrobial coated catheters, they may be having a combination of chlorhexidine or minocycline rifampicin. Efficacious in preventing catheter-related bloodstream infections by prevention of bacterial colonization in the catheter. Immensely useful in immunocompromised patients, transplant patients, those who are going to school for a long term in the ICU and therefore require long-term cannulation. By reducing catheter-related infections, these special types of catheters, they reduce the cost of hospital stay and also the duration. Now, what are the indications of catheters? So, major operative procedures where major fluid shifts or major blood loss is anticipated. Intravascular volume assessment, especially when urine output is unreliable or unavailable, as in patients who are having renal failure, patients who are having cardiac failure, where even a small amount of fluid administration can lead to fluid overload and heart failure. Major trauma patients, procedures which involve a high risk of venous air embolism, as in case of sitting position failure. Conditions where frequent sampling is required, like long-term admissions to ICU. So every time we pick and take a sample, it's not justified. So it is better to put a wide bore central venous catheter from where sampling can be done daily. Access for vasoactive drugs. Now, vasoactive drugs should never be given from peripheral lines because it can lead to extravasation and local tissue necrosis. And in any case, they require a wide lumen vein for administration. So if we are administering to vasopressor to the patient, then we should insert a central venous catheter pressure. Inadequate peripheral access, this may also be the reason for inserting a central venous catheter sometimes. And of course, to give total parenteral nutrition. Now, what can be the complications of central venous cannulation? So, arterial puncture or hematoma is a number one. Then, AV fistula, pneumothorax, pyrothorax, these have been reported. Nerve injuries, brachial plexus injuries, late ganglia injury, air embolism can occur. Guide wire embolization. This is a very dreadful iatrogenic complication which can happen, especially when small size catheters are being used, and sometimes the guide wire being very small, it can get accidentally, it can get flushed through the catheter into the bloodstream of the patient, and it can be fatal for the patient. Even if the patient survives, we have to take the patient to cath lab and get that guide wire removed from bloodstream with the help of a snare. So it is a very dreadful complication. You always have to take care that the guide wire should never go inside the circulation. Then the RA-RB perforation, these are also very rare complications, but they have also been reported. Arrhythmias can occur during insertion of the central line, and that can also lead to hemodynamic instability. Infection, sepsis, and endocarditis, these are also long-term complications which can happen with insertion of central venous catheters. So what are the possible questions that you may be asked on central venous catheters? First and foremost, is the identification of the site of the catheter. Indications, complications, which may be during the procedure or long-term complications. Now, in this picture, you can see the components of pediatric central venous catheter. So you can see that there is a locator needle 22 gauge with a 2 mm syringe. Then the puncture needle, which is 21 gauge, then guide wire, then the knife, dilator, and the catheter, which is 4.5 to 5 French in size. And the length of the catheter varies between 5 to 8 centimeters. Normally, in kids who are less than 5 kg weight, we would choose to insert only at 5 centimeters. And as kids who are more than 5 kg weight, we can insert length more than 5 centimeters up to 8 centimeters. So they are required in pediatric cardiac surgical cases and long-term stay of pediatric patients in the ICU. Sometimes also peripheral access is not available. If the child requires IV administration, then they may need to insert a central venous catheter for this purpose. So you may be asked to identify a pediatric central venous catheter, the size of puncture needle, the size of the catheter, indications and complications, and how to manage anesthesia for the child who come to get a central venous catheter inserted and doesn't have any peripheral IV access. Now, this device that you see here, it is a CVP manometer, and it is still used in some modern monitors may not be available, and was used very extensively in the past when monitors were not available with pressure transducers, as we know now. So this device is recently attached in the upright position to an IV stand by the patient's bedside, placed in level with the patient's heart. And at one end was connected and a fluid-filled bottle with the help of an IV set. And the other end, the pressure line, which you see attached to the manometer, that used to be connected to the central venous line. So the CVP was measured with the help of the fluid column, which we see in this manometer. Now, this is a modern pressure transducer which we have now, which are attached to our monitors. And these are also connected in a similar way to the central venous catheter. And the other end is connected with the help of electrical connection to the monitor itself. So they convert the mechanical impulses which they are getting from the central venous catheter into electrical impulses, which is demonstrated on the monitor as a waveform as well as a digital value. Again, the possible questions can be that you identify the equipment and say what are the parts of the equipment, how CVP is measured, and the advantage and disadvantage of using a manometer and a pressure transducer. Thank you.
Okay. Thank you, Dr. Indra, for nicely illustrating the most of the aspects of central venous pressure measuring and monitoring. And so rest of the discussions and question answer we'll have that at the end. And you have given a list of questions also, which are possibly can be asked, and there can be additional questions if the participants wants to ask more questions. They can put it in the chat box, and we can discuss at the end. So now I hand over to Dr. Ashok Saxena to introduce the next speaker for the session. Thank you, Dr. Indra, once again for the nice illustration.
Thank you, Dr. Dali.
Thank you, sir.
Thank you. Well, very good evening, ladies and gentlemen, and of course, our bright budding anesthesiologist. At the very outset, I wish to express my deep gratitude to the organizers. You know, all of them, of course, they have taken a great initiative in these tough times, as Dr. Dali said, and hats off to you and my heartiest congratulations. Well, this is where now we move on to the next topic, that is on safety features in anesthesia machine. And the person who is going to enlighten us on this topic is Dr. Geeta Erawat. I'm sorry, I don't have her CV, but I'm sure she's a senior professor at PJMS Rohtak. I hope I am correct. Dr. Geeta is a senior professor at PJMS Rohtak. She has a large number of publications to her credit. She has delivered a good number of guest lectures in various conferences, workshops, seminars, etc. Her special assets are, you know, that she's almost, you know, she's specialized in the details on anesthesia machines. In addition to many other areas, you know, including of course, the supraglottic airway devices and pain management. And a lot more can be said about her, but I don't want to come in between Dr. Geeta and the budding anesthesiologist. But I would just like to highlight just one or two lines. Is that, you know, that I'm sure she is going to move on right from the Boyle's machine. Many people are still using that onto the advanced anesthesia station, like you have the Drager one, the Drager Primus and Drager Fabius and all those things. And I'm sure these young budding anesthesiologists are too eager to learn about that, because they're, of course, they're there to revise their knowledge. And that includes, you know, things like SORC, or sensitive oxygen ratio controller, or many other aspects where you want to ensure the oxygen delivery. You have various audible and visual alarms. And in case of complete oxygen pipeline failure, I'm sure she's going to enlighten you what to do. Right. And then I'm sure she will move on to safety devices in the flow meters, you know, right from the basic one to the electronic flow meters. And then what happens with the vaporizer, the trace vapor output, you know, which keeps on happening even when the vaporizer is off. And then finally, I'm sure she's going to enlighten you on the fresh gas delivery and the breathing system. We have one of the most basic features. And then finally, she will move on to how to actually determine the compliance of the breathing system, because there are things like the piston designs and many other things, and how exactly much more additional volume can be delivered to compensate for the breathing system compliance. You have ASTM standards, and last but not the least, I'm sure she's going to enlighten you. If there is complete exhaustion of the pipeline oxygen system, right? And if you find that even all the cylinders are empty, am I right? Everything has failed. Then what exactly is the best anesthesia station which can work even under these circumstances? So Dr. Geeta, for enlightenment on this particular topic on safety features in anesthesia machine. Dr. Geeta, please. Thank you.
Very good evening, sir. Thank you so much. I'm not that senior, and that a lot more. I'm so thankful to you for enlightening me so much about the machine. And sir has already explained my topic. As I wrote, it is an ongoing journey. The anesthesia machines are an ongoing journey, as is evident also from what sir has said. But for I really thank all the organizers. Am I audible? Am I audible, sir?
Yes, ma'am, you are very much audible, ma'am. Please carry on.
Yes, audible.
Thank
audible,
you.
very much.
Thank you so much. At the outset, I am really thankful. Very good evening to all my respected seniors and all the seniors in the meeting. And I'm really thankful to the organizers for giving me an opportunity to talk to the PG students about a topic which has made all of us so powerful. It is the biggest thing that we have, and the most precious thing, and we really need to know about it in detail, and even check it, and the importance of checking and keeping it safely and maintaining it safely so that we can give safe anesthesia by it. So to begin with, I would say it is an ongoing journey. As sir has mentioned, anesthesia machines are changing, and maybe some of the postgraduates listening to me will come up with better designs in future to help all of us out. But talking about the safety, as we move on with the lecture, I would like to say one miss can land you in an abyss. So each and every part of the machine, each and everything as we discuss is of equal importance and needs to be understood and maintained and stressed upon. Even if I miss it, it has to be in complete tandem that it works. Only then it is an anesthesia machine which will help all of us. As a very popular analogy, I would again stress upon the fact that just as a jet flyer takes off, you have to be that serious. Anyone could fly a jet, but it is only on the safety checklist that the jet is allowed to fly. So the safety and the checking of the machine is more important than the machine itself. And you have to go through rigorous checking, rigorous maintenance, that you can really take up a case before going surely through all the machine and the equipment revision, wide checklist through all your members of the team. They should be well aware of all the resources that you have before taking up a case. The chronology as we go through it is right from, as sir has mentioned, the early man who used and the earlier times where a stone was used to give anesthesia. Then it gradually moved to, as you can see, various machines as and when with the progress of science and technology to the most equipped and the most fashionable machines, well-equipped machines that we are using today. But the basics never change. The modern machines have two major components. One is the electrical and the other is the pneumatic. If you talk of those machines which are not using electricity, the boils, etc., they are the pneumatic component, which is the prime one. But both of them, both the components are equally important. And if it is a pneumatic machine, whether or if it is an electrically driven machine, all necessary checklists are equally important as the machine may be. So if you let us talk about the electrical part first, we are all sure of the master switch, which keeps our machine on. Power failure indicators are equally important because now we are depending on the power. So we also should have a reserve power like any battery. Electrical outlet should be checked before you check the machine. All circuit breakers should be in place before you switch on to the machine. And then now in this era, the data communication ports are equally important. Pneumatic part, coming to the pneumatic part, however high-tech the machine may be, the basic design remains the same. It has three basic divisions, where the high pressure system, intermediate pressure system, and the low pressure system. In the talking of the high pressure system first, we have the yoke assembly, yoke hangers, where a cylinder attachment, because the machine started basically on the cylinder. Now we have pipeline facilities, but still we depend on cylinders for our backup. So the yoke assembly on which the cylinder is hung, it is kept straight by this yoke. It is because of the yoke that the cylinder can give us. It can be connected well to the machine. It is of equal importance. Then there is a cylinder pressure gauge, which tells you what is inside your cylinder, how much gas is left at each and every moment, and the pressure regulator valve, which allows you to use the pressure. Yoke hanger, as is visible to us, as we are well aware. To my postgraduate students, the first question you can be asked is, what is a yoke? I hope you understand what is a yoke. You must have seen a bullock cart where two bullocks have a yoke on their, they are pulling a cart because of the yoke which connects them to the cart. So similarly, this yoke connects our cylinder to the machine. It has a body, it has a retaining screw, it has a nipple and the index pins, washer between the machine and the cylinder with filters and check valve assemblies, and a gate which tightens it and keeps it straight. So when another important feature on a cylinder is the pin index. So what is a pin index? It is a marking on all the cylinders. It is a conventional safety system where 12 degrees apart, an arc of 60 degrees, places 1 to 6, as you can see on my screen. 6 points are marked at a difference of 12 degrees each, which have been conventionally allotted to various cylinders as depicted in this table below. For example, oxygen is 2,5. So oxygen cylinder will have a depression at the point corresponding to 2 and 5, which will match with the pins on your pin index. So the cylinder will be connected. It can only be connected if it matches the pin and the yoke holds it in place and sufficiently presses when the yoke hanger is tightened on it. And then I'm sorry, I lost the. Yes. The pin index safety system is a safety system which is of importance to you in theory as well as in practical. It can be asked to you. It is of prime importance, and you should make sure when you are changing cylinders and connecting to it, you should know all about the pin index. It comes as a theory question, as a short note, as well as it can be asked in the practicals. It was proposed in 1952 and has been used by various nations, and you should know, just as I mentioned, it is specific for gases, and the details I have already described. So there is a check valve assembly to prevent the retrograde flow of gases. You can change the empty cylinders. However, leaks can occur, and you can close the valve when required. However, it can fail if the pins are broken, if there is a double washer, or the pins are pushed inside, or the yoke block has been put upside down. Then we talk about the pressure gauge. Now you have a cylinder, but you should know all the time how much pressure it has. So Borden's pressure gauge was the one which was initially used. These pressure gauges had a tubing which were coiled, and they would straighten up as the cylinder pressure increases, as you can see. This was connected to a needle which will show you from outside how much pressure your cylinder has. But it was, apart from this, it was also at an angle which you could see, and it was color coded always. Now in the modern machines, you have color coding is there, but they are fixed on the upper part of your machine. Then comes the intermediate pressure system. This intermediate pressure system receives gases at a reduced pressure. The higher pressure was getting gases from the pipeline as well as from the cylinders directly. Now the intermediate pressure system receives gases at 37 to 55 psi. This includes the flow meter assembly, the pipeline inlet connection, pipeline pressure gauges, ventilator power outlet, oxygen flush, and oxygen pressure failure devices. To talk of the pipeline inlet connections, there are non-interchangeable connections are preferred. Now we have the diameter index safety system. Here again, quick connectors are also there. These connections are touch coded, they are color coded for different gases, and they can be connected by different holes, and their connections are specific. They are company specific also, but generally in our institute also we have 3 types of systems. So you should be sure of what machine, what pipeline, what connections you have, because at times in one theater, the other theater machine from the other theater is pushed and it is brought here, but you should always ensure whether it can be connected, especially the newer buildings are having newer connection systems. So it is of prime importance. Don't rely on a distant thing. You must always ensure, bring it, connect it. And actually, if you are able to connect, ensure and then go for the use of it. So we have auxiliary oxygen outlet. Apart, we've been talking of cylinders and the pipeline system. We also have auxiliary outlets on the machine, which are a part of this system. Then the oxygen pressure failure device. When we are so much concerned about the oxygen and the hypoxia, I think after COVID, everyone knows the importance of any kind of oxygen pressure failure device, supply shortage. We've all gone through it so much, and so we've seen what happens when you don't know what your resources are. So oxygen failure devices prevent, because hypoxic mixture, when we are using oxygen along with other gases. So hypoxic mixture delivery can be a major problem. There have been many accidents in past. All theaters have histories to say, all machines have their own histories. So what are the options to prevent this? We should be able to cut off the supply of gases other than oxygen. We should have alarm systems, whether audible, visual, or audiovisual alarms. Our standard guidelines, they mention that any anesthesia machine should be equipped with a device which would immediately detect the pressure fall of oxygen. And if the oxygen pressure goes below 50, it should be able to cut off all other gases, including medical air. So with this in mind, we must have our oxygen pressure failure devices absolutely right. The hypoxic devices, hypoxia prevention safety devices also are a part of our modern machines, like minimum mandatory flow. Just as you switch on the master switch, even if you are not open the knob of the flow meter, a minimum mandatory oxygen flow will be seen as is visible in this figure. This can be from 50 to 250 ml per minute, depending upon the machines. Then there can be mechanical linkage system between your oxygen and other gas nozzles, which ensure that if the oxygen is of course opened after a certain limit, that is minimum of 21%, and then if that is open, only then the second gas will open. Plus, if for some reason the oxygen falls, the nitrous or the other gas, air or anything else would automatically be switched off. Same thing is there in the electronic systems, where the linkage is the electronic system will provide you that minimum ratio of oxygen to other gas mixture. Then we have the various alarms. These alarms again could be electronic and pneumatic. Pneumatic would give you a whistle, which would have different sound in it. Once it's silenced, that means you are out of the problem. Electronic alarms would have an indicator, as is shown here. When there's a failure, it would be color coding for the different alarms. These alarms could be silenced after a certain time, but they cannot be disabled. So these alarms, these oxygen devices are really helpful to us, but still they have their own limitation because they depend on pressure and not the flow. They don't guard you against accidents if there's a pre-mixing, if the cylinder of oxygen has been wrongly filled, or the pipeline of oxygen has been crossed over by some other gas. Then there are operative errors and leakages downstream to this device. But still, whatever we have is our best guard, and we should check and have these in proper place. Then comes the flow meters. We are all well aware we are well aware with the flow meters, which has a THOPS tube. It has a background, which has a fluorescent background, which would, in case there is darkness in the theater, it would reflect. At least you can see your flows. Then, as you can appreciate, there are the knobs of this. It has a body, and then you can see the THOPS tube and the flow control knob. Flow control knob plays a very vital role in the functioning of the flow meter. They are touch coded. They are color coded. As I said, if there's no light or if you're busy ventilating a patient, your hand should know what knob are you operating and opening. So they are touch coded, their size is different, and they are at a minimum distance apart, at least 25 mm they should be apart, so that you can have, you don't unnecessarily open the other one or disturb the other one once you are trying to use another knob. In the newer machines, you can appreciate that there are digital flow meters with the most modern machines. So as I told you, these knobs are gas specific, they are color coded, touch coded, and they are at a minimum distance apart. Their arrangement of these flow meters could be in series, where a lesser flow, especially for the oxygen, can be in one tube, which is in series in continuation with the tube, which gives you more flow. So the flow meter, the reading would be which is on the top of the higher flow meter. In case of other gases, it could be a parallel arrangement. Now these two have their limitations, like there can be inaccurate reading, or the float or the bobbin that rotates sticks on the top, or there's blockage of the tube, or the reading can be and there can be leakages. Flow meters, the arrangement of the flow meter is very important. As PG students, you must have seen, if you have seen, there are machines the arrangement of the flow meters is important. If you stand in front of the machine, earlier machines had the oxygen outlet on the right, flow meter on the left as you stand in front of the machine. Then it came to the right side of it. Then now it is again on the left side. But internally, oxygen flow meter is positioned downstream from other flow meters, and it is closest to the common gas outlet. That is kept in mind. However, the arrangement may be seen from outside. Internally, it is always positioned downstream and it close to the common gas outlet. Because this is just a small effort to prevent any kind of hypoxic mixture delivery in case there is any leakage in the pipe. Still then, there can be leakages still down to it, but that is whatever maximum can be done to prevent is this, that it should be kept downstream and nearer to the common gas outlet. Then comes the oxygen flush. This oxygen flush is a lifeline for all of us, and at times it saves you from many problems. This is also a part of the intermediate system, and it can deliver unmetered oxygen from 30 to 65 liters per minute. It is independent of the master switch. It is a self-closing type, and generally it is cushioned and kept inside a jacket kind of a thing, as you can appreciate, so that you don't inadvertently push it. It must have saved you many times when you have made some mistake of not changing the knob to the bag or the ventilation type, and still you've started inducing, or there is some problem with the machinery, or you are not adequate help is available, or you're a single ventilator person, you're stuck up in some situation. This is our biggest savior, and it should be ensured and checked thoroughly before taking up on the machine. Activation of this flush, however, it can produce a pressure change in the in your machine circuitry itself. The vaporizer output can be altered, flow meter readings can be changed. However, you can accept it at any time. The vaporizer outlet should not be disturbed more than 10, and the vapor output should not be disturbed more than 20%. But however, still, it should not be depended on. It should not be kept on for a long time, as it can itself cause barotrauma. It is an emergency help and should be treated and used as an emergency help. Now coming to the low pressure system, from the outlet of the flow meter to the common gas outlet. So here all of us are aware, it houses the back bar, vaporizers, and back pressure safety devices, and the common gas outlet. From the flow meter, nowadays it is not visible. You can see it very clearly in the Boyle's machine. There was a pop-off valve which would pop off in case there is any kink or any back pressure, so that the patient is saved and it does not cross to the common gas outlet. Vaporizers head are mounted on it. It makes place for the selector-tech arrangement and leads to the common gas outlet. Vaporizers, as we know, are as highly fashionable and available to us as are the makes available to us. Most of the machines are specific. They have their specific vaporizers and interchangeable, where you should always ensure now, because in institutes which purchase different kind of machines, a variety of vaporizers are available. They have their own check fills, and they are specific to different machines. So whatever you don't be sure, okay, I have this vaporizer and I can use it. You should always ensure whether it matches. It can be mounted onto your machine. The filling apparatus that you have is compatible with that vaporizer and is actually functioning. So you should put it, check, and it is an important part of the checking this thing, that you should ensure that it can be mounted. Like in this figure, I'm showing you two kind of vaporizers. They are not interchangeable. You cannot put a dragger vaporizer on this machine. Then you should also see that selector-tech mechanism is maintained. So these vaporizers are color-coded, they are touch-coded. The feeling of, they are press and rotate. If anyone just tries to accidentally rotate, you cannot rotate. If one vaporizer is open, the other cannot open. So you can appreciate press and rotate techniques. Then they're temperature controlled, they are agent specific, they have an interlock system so that two gases cannot be delivered even if someone makes a mistake. So, these vaporizers have to be checked for, and the older ones, you must remember that the gas in this should not be very old. The color of the gases should be ensured if suppose somebody on a Friday, you are using it on a Monday, you should ensure how long the agents have been inside this vaporizer. Some machines have pressure relief valves near the common gas outlet, as I told you. The whole aim is, these valves open to the atmosphere, and the whole aim is that the pressure is in any way is not transferred to the patient, and it is relieved before the common gas outlet. This was very clearly evident in the older Boyle's machine and is not seen. However, it is present in the newer machines. The common gas outlet is the exit point of all gases and vapors. So this is it has a gas pressure about 4 to 8 psi, and we all have a tendency of taking this common gas outlet, I think, is the most taken for granted part of the machine. But I tell you, it is the most important part of the machine, because if you are not going to check this, all the exercise that you've done so far is useless, and it is this outlet which has to be absolutely clean and clear, so that whatever high-tech machine is standing behind you helps you to connect whatever circuit you get and deliver what you intend to the patient in front of you. Just to revise the safety features, whatever many things have been covered, but what is not covered are some few things like the wheels. These wheels are anti-static wheels. And these wheels are a very, very important part. You must have dragged the machines, and you must be thinking that their main function is transport. But more important function that they do, more than the transport, is that they keep your machine straight and parallel to the floor. And that is why all the flow meters, all the vaporizers deliver a certain value of a gas which you intend to give. If one of the wheels is broken, or if the machine is tilted to a side, your flow meter cannot show you a correct reading, your vaporizer does not deliver what you intend to deliver. So your wheel should be absolutely good, and the machine should be straight. There should be no compromise on the wheels. They have an anti-static covering to prevent any static charges from in between the floor. Although the OT floors are also non-conducting nowadays, but still this is another safety feature. It also has a front wheel locking bar, so that the machine itself doesn't, hamper you and your movements when you are performing a certain procedure. Then there are the color coding of the cylinders, provision of 2 cylinders on each machine, pin index, pressure gauges, as we've all said, oxygen failure devices, 1 or 2 auxiliary outlets as the machine, and depending upon the make, so that you can nebulize your patient, give an extra oxygen supply, use it for attaching a Bain circuit. Nowadays, we are attaching the Bain circuit to to the auxiliary outlet, to the alternative supplies. In spite of the machines and the safety checklist and the safety features and the makes of the machine, we still cannot rely and cannot think that we are confident to start a machine just by having a good make and a costly machine standing behind you. Machine check should be done in a it should be taken as a drill, and it should be started from 1 to 0.8 daily and daily and daily without fail. This is my sincere request, and this is a thing which should not be remembered, which should not be forgotten, even if whether you are a student or a teacher or in any position in the fraternity of anesthesia. So when you talk about the checklist, we should first think, we should talk about the emergency ventilation equipment. Even if this machine standing behind you fails, then what? The high pressure system falters, then what? Each system should individually be checked. High pressure, low pressure, scavenging system, your breathing systems, all the ventilation that we've talked about, all the monitors that you have, and what is my final position after checking all this? Should I go ahead or not? Am I equipped or am I not equipped? And if I'm not equipped, am I short of some resources? Can they be made available to me? Or if the case is an emergency, do I move ahead? If I do move ahead, how? What is my help? So FDA recommends, even if you are step number 1, even if you are very, very sure of whatever ventilation backup you have, the baseline never changes. Our ambu bag is our savior again and again. Check the supply, oxygen cylinder supply. I think this drill has already been imbibed into each anesthesiologist in times of COVID era. Check the oxygen cylinder supply. Check the open that cylinder. Do you have a lot of oxygen cylinders? You don't have a regulator on it. You don't have the key to open it. Please open it and verify. The cylinders are heavy enough. You cannot identify from seeing a cylinder whether it is full or half. So open the cylinder, verify at least it is half full. If it is half full, you go ahead. Otherwise, and arrange for the next. Below that, it is risky. Close the cylinder after you've checked it. Otherwise, when you'll actually use it, your cylinder is already empty. Then check the central supply lines. They are behind each machine. You have check the machine end also and the end in your theater where the connections are. Ensure now another step has been added. You confirm from your gas manifold also what backup you have, how many standby cylinders you have. This is a drill which COVID era has taught all of us in spite of checking all this. Your suction apparatus should always be ready. Your low pressure systems, flow control valves, vaporizers, check all the connections whether they are in place or not. The leak checks, as you people are doing every day, with the master switch off, connect a suction bulb to squeeze it, press it. When the machine is off, there should be no gases coming out of it. And this bulb should stay collapsed for at least 10 seconds. Open one vaporizer, then again test it. Open another one, reconnect it. There should be nothing coming out of the fresh gas outlet with the machine master switch off. Only then go ahead. Then your master switch, when you switch it on, there has to be some audible sign so that you do not, if you happen to inadvertently switch it off or someone else does it, so you are immediately aware of it. Test your flow meters for all the knobs and all things that we talked about. Check your scavenging system if you have some. Many institutes don't have this facility, but if you're in a position, check it thoroughly. Check your APL valve, occlude your YPs, see that nothing comes out of it. Then you release your APL valve and see that there is a change or not. Calibrate all your oxygen monitors. It should show you 21% on room air and verify your low pressure alarms. Then you open the oxygen and immediately your reading should be more than 90. Check your breathing systems. Check your breathing systems for any damages, any torn, this thing. And after checking all the ventilator, please ensure that you bring the selector switch back to the back mode. This is a very common mistake done by all the postgraduates and the seniors also, including me. We end up in our, urgency to start the case, or we are, we tend to see, oh, this is such a difficult case. In our preparation for the patient and our more focus on the patient and the arrangements, we forget, we check the machine, but we just start off especially in the emergency theater, we forget to put it on the bag mode, which is very, very important. CO2 absorbent should be thoroughly checked. When was it changed? What about the color coding? Install every breathing circuit accessory. Have your checklist ready and ensure every resource what you have. Leak checks, again, as I told you, APL valve, you should just pressurize your breathing circuit to about 30 centimeters. Your APF valve should not pop off, and then you remove it and see that immediately the pressure should fall. Ventilation system, your bellows should be verified that they are active during inspiration, they're fully filling, then they're giving adequate tidal volume. Set your fresh gas flows to about 5 liters and verify it. Verify the bellows are completely emptying. If you have a test lung, you can see how it fills. The feel of the bag is the best thing, which is, we are most accustomed to. You should be, when you hold the bag in your hand, you should be confident of the resistance and the compliance of the bag. And this is a thing which you learn over 3 years of your post-graduation or your experience as you move ahead in the functioning as an anesthetist. And the feel of the bag is the thing which gives you the most confidence. Your hand should tell you, make use of all your 6 senses. Your ears should tell about the alarms. Your hand should tell about the touch coding. Your hand should tell you how much the bag is filling or not. Your ears should tell you about the alarms, and your eyes should be able to detect anything wrong going on with the patient and the equipment that you have. Check all alarm limits. And for all the monitors, you have a pediatric case followed by an adult case. You don't change the alarm limits when you're in the most crucial time of your induction. Your alarms will instead of helping you out, they will be scaring you. So please set all your alarm limits and then move ahead. Check final status of the machine. Vaporizer should be off. APL valve should be good. Again, I repeat, selector switch should be on the bag. All flow meters should be 0. Breathing circuit should be ready to use. Suction apparatus should be available to you. Having done all this, this should also be completed on paper. All documentation of complete checkout procedure should be done. These modern checklists, whatever we've mentioned, the conventional tests may not be possible in many of the modern machines which have automatic checks, self-tests. But their self-tests are, then these machines, you should ensure that they are regularly serviced so that the self-tests are dependable. You should have at your one hand glance, when was the machine serviced? Are the checklists and check self-tests all okay? They are good, calibrated, then move ahead. If you're using the same machine for successive tests, you need not go through all the tedious tests, but a keen eye should be there in between changeover of all the cases. Just to summarize, please verify your backup ventilation equipment. It should be available and functioning. Check all your supplies, check the initial status, check all leak tests, all your switches, all your flow meters, scavenging systems, and calibrate all your monitors. Safety is prime, safety saves us, but a small reminder to all is all this is useful. It is like a parachute. A parachute is useful only if it is open. If you jump with a closed parachute, it is as good as jumping without it. So please, all these machines and equipments are only useful if you abide by the safety guidelines, follow the checklists, and then use them. Similarly, questions would be asked to you. This is a very important part in theory as well as practical, because it is important for you as an anesthetist and to your patients whom you are going to give anesthesia. Thank you so much for your patience.
Thank you so much. Thanks, Dr. Geeta. Thanks for wonderful swing, right from the most basic aspects to the advanced and the modern versions. And, in the modern times, the modern anesthesiologists, as our young budding anesthesiologists are, you really summarized everything so quickly and so enormously that everything was, really beautifully touched upon. And I'm sure we are going to have questions right in the end. That's what we have decided. And you wonderfully talked about that, yes, when exactly you are going to, get your nitrous oxide shut off, that's really, and that's where, if we talk about the modern anesthesia machines and the workstations, so if the oxygen flow is less than 200 ml per minute, yes, or if the oxygen fresh gas valve is closed, yes, definitely the nitrous oxide supply is cut off. You very beautifully summarized that. And yes, I'm sure these young anesthesiologists, they also know very well that there are certain machines like the Drager primers which can function. As I said in the beginning, that even when all the cylinders 2 are empty, well, it should not happen. Yes, as you very rightly emphasize, why should the cylinders be kept as empty? But if at all they are empty, and if at all you find there is complete exhaustion of the pipeline, oxygen supply, yes, there's only one apparatus, and that's one modern version, Drager primers, which can function simply because, it has been functioning on the piston-driven ventilators. The piston-driven ventilators obviously do not require oxygen, unlike the one which you talked about, the oxygen-driven bellows of the pneumatic ventilator, right? So these are some of the things which I'm sure in the end people can always discuss it out. Thank you so much. It was a wonderful lecture. Even for me, I learned a lot from you. Thank you so much, Dr. Geeta. God bless you.
Thank you.
So this is the time when I should hand over to my dear colleague for the next topic. For the next topic on DLT of the double lumen tubes, we have a learned chairperson, Dr. Nishkarsh. Yeah, please, could you? Thank you so much. Thanks for the opportunity. Thank you.
Monisha ma'am,
Good evening, everybody. I would like to thank the organizers, first of all, for inviting me to be a part of this academic feast. Our next speaker is Dr. Swati Chhabra. She is presently an associate professor at All India Institute of Medical Sciences, Jodhpur, and she is a governing council member of RSACP. She was awarded Proficiency Award by ISA, and she is an associate editor of the Indian Anaesthetists Forum. She has several publications and chapters in various books to her credit. And today she will be talking about double lumen tubes, which is a very important and a favorite gadget to be asked by all the examiners, and it generates a lot of questions, not only to DLT per se, its technique of insertion and checking, etc., but the physiology of one lung ventilation, the VQ mismatch, etc., etc. So over to Dr. Swati for her presentation.
Thank you so much, ma'am, for that introduction. I thank the organizers for giving me this opportunity, and let's begin with this photograph. This tube is lying there on the table viva, on the table for the viva, and residents are there, examiners are there, and it's a tense situation. So question comes to my mind, and senior examiners can comment upon this. Does a candidate get brownie points if they pick this device when the examiner gives them a choice? So maybe a few residents will pick the device up after this discussion. So as we can identify, these are the double lumen tubes, and over next 15 minutes, we'll be discussing some important exam-oriented points. So the questions during the table viva, they are usually following a fixed path, but the candidate himself or the examiner can steer the discussion and the question answers to a deviated path. So I'll be mostly focusing on the fixed path, and because discussing all the physiology of one lung ventilation will be beyond the 15 minutes time I have. So let's just start with this. The very basic airway anatomy, which is totally applicable to the insertion of double lumen tubes, are depicted in this picture. These are for an adult whose height is around 170 centimeters. So we can see that the distance from the mouth, opening of the mouth till the larynx is around 15 centimeters. From the larynx till the carina is 12 centimeters. And for the right mainstem bronchus, till the takeoff of the right upper lobe bronchus, it's around 2 centimeters. And on the left main bronchus till the takeoff of the left upper bronchus is around 4.5 to 5 centimeters. With this basic knowledge, we'll move ahead and describe the device. So how will you describe the device? So the device has a separate tracheal and bronchial lumens, and each tube has a D-shaped lumen, and they are fused in such a manner that the straight part of the D are fused together. The shorter tube has a high volume, low pressure tracheal cuff, and the tracheal lumen is positioned just above the carina. Longer tube has a low volume, high pressure bronchial cuff, and ideally positioned just below the tracheal carina, but before the takeoff of the anilobar bronchi. And these tubes are labeled either left-sided or right-sided, depending on which mainstem bronchus the longer tube is designed to fit. And the cuffs, palate balloons, and connection apparatus are all color-coded. So white is for the tracheal tube and blue for the endotracheal tube. Now you may be asked to name a few double lumen tubes. So here are a few names: Carlins, Robertshaw, White, Bronchocath, etc. And previously red rubber double lumen tubes were used. Now mostly are disposable PVC ones. There are few design variations. In the basic description, mostly is the right bronchial cuff, which may have a cuff. There's this blue bronchial cuff which has a slot, which should align with the right upper lobe bronchus. And there may be another variation where there are two bronchial cuffs and a slot in between to align with that. Then the tube may have a carinal hook as an aid to proper placement and to minimize misplacement. However, there are some issues with this hook, It may in itself cause difficult placement. It may get stuck in the vocal cords, can cause trauma, and interfere with the bronchial closure being done by surgeons, and it may become a potential foreign body if it breaks off. The tubes which have a carinal hook are the Carlin's tube and the white tube. Another design variation is video enhanced DLT by Ambu. In it, a high resolution camera and light source is embedded on the distal end of the tracheal lumen, which may facilitate accurate placement and allow continuous video monitoring of the DLT position during surgery. So this is a very interesting variation. So what is there in the box? So when we unbox a DLT, there is a left or right sided double lumen tube. Then there is an assembly of connectors which are color coded. Then there is a Y piece and appropriate length suction catheters are included. And also you can see a stellate which is already inserted in the bronchial lumen. Now you may be asked about the indications, which can be categorized as absolute indications and relative indications. The absolute ones are isolation of one lung from the other to avoid spillage or contamination. And when you want to control the distribution of ventilation, like in bronchopleural fistulas, etc. And when there is a need for unilateral bronchopulmonary lavage. And relative indications are some high priority surgical exposures like the ones for thoracic aortic aneurysms, pneumonectomies, thoracoscopies, and upper lobectomies. And some medium priority surgical exposures are middle and lower lobectomies and subsegmental resections, esophageal resection, etc. And there are few contraindications too for DLT, like anatomic barriers that make positioning improbable or dangerous, like carinal or bronchial lesions, strictures, vascular compression by aortic aneurysm, and aberrant bronchus. Now, how does one select the double lumen size, double lumen tube size? So we go for the largest DLT, which is likely to fit easily within the mainstem bronchus. Ideally, the outer diameter of the bronchial tube should be 1 to 2 millimeters less than the internal diameter of the bronchus it is intended to fit in. And the most simple and effective method for making a choice is patient sex and height. Although radiographic measurements of bronchial or cricoid ring diameters have also been used. With an appropriate DLT size, there is air leak when the bronchial cuff is deflated, but it should be airtight when the cuff is inflated with a volume that is less than 3 milliliters. Oversized DLT may traumatize or even rupture the trachea or bronchus, and obviously is not recommended. Undersized DLT is also a big no, and it may lead to inadequate lung isolation, increased airway resistance, overinflation of the bronchial cuff, and accidental passage far enough into the bronchus to obstruct the upper lobe of the lung. So this is the table all of us are aware of. According to the height and sex, the tube is selected. For males, it is mostly 39 or 41. For females, 35 to 37, depending on the height in centimeters. And it is interesting to know that these tube sizes are in French. This is because the individual tube is not round in shape. They are D-shaped. So it is difficult to know the internal diameter. And since two Ds are fused, what we get is the French. And it is known by knowing the widest part of the outer diameter of the combined tube and multiplying that by 3. And as per the pediatric sizes, the smallest cuff DLT is 26 French, which can be used in children as young as 8 years of age. For children 10 years or older, we have 28 and 32 French DLTs. Now coming to positioning, so we'll be first discussing the left DLT. So left DLTs are generally easier to place than right ones. So we can use a direct laryngoscope or a video laryngoscope for the purpose. After the standard induction, the endobronchial tip is inserted through the vocal cords. The stellate is removed once the cuff passes through the vocal cords to avoid the trauma, and the DLT is rotated 90 degrees to the left while being advanced. And after appropriate depth insertion, which is predetermined, we are going to confirm the position. But we should be aware that about 24 to 39% of blind insertions of left DLT, which are not confirmed with fiber optic bronchoscope, will result in endobronchial intubation of right mainstem bronchus. So there is a maneuver to overcome this, wherein we turn the patient's head to right and tilt it towards right shoulder while advancing the tube. This may help to avoid the right mainstem bronchus during insertion of left-sided DLT, and this maneuver has a success rate of 92%. Now coming to confirmation of placement of left DLT, and this slide will hold true for a right DLT also. Most common method which we use are auscultatory, but the current standard of practice and gold standard is use of a fiber optic bronchoscope. And for a 35 to 41 French DLT, bronchoscope of less than 4 millimeter in diameter is required, and for 32, a bronchoscope of less than 3.4 millimeter in diameter is required. And we must also know that it is critically important to reconfirm tube position after any change in patient's position. Chest X-ray has also been used, but it is not as sensitive, time-consuming, and labor-intensive for confirming this. And most of the institutions and setups have standards of practice of using fiber optic bronchoscope these days. Now, when we use a fiber optic bronchoscope for confirmation of placement of left DLT, we first insert it through the tracheal lumen. And what we see is, just as we reach the tip of the tracheal lumen, what we can see is the carina, wherein we can see the right main bronchus and tube entering the left main bronchus, and we can just see a blue cuff. And if this is since this is inflated, we can appreciate that it is not herniating over the carina or entering the right mainstem bronchus. Then we can go further and enter the right mainstem bronchus and towards the right upper lobe and identify this trifurcation sign, which are the 3 segments from the right upper lobe segment. Furthermore, we can insert the FOB through the bronchial lumen, and just as it exits, we can see the division of the left mainstem bronchus into 2. Now, auscultatory confirmation is widely performed, should be done, but it is not possible to do this when there is position change or some misplacement. When the patient is covered with surgical drapes, it might not always be possible to do auscultatory confirmation. Still, it is important to know how it is done. So after it is placed, the DLT is placed, we ventilate as a part of step 1, we ventilate through both tracheal and bronchial lumens. If there are equal breath sounds on both the sides, then we go to the step 2. However, if there is decreased breath sound to the right side, please mind this is a left side DLT, and while ventilating through both tracheal and bronchial tubes, if there is decreased breath sounds to the right, this means both the endobronchial and endotracheal lumens are in the left mainstem bronchus, and obviously we'll have to withdraw the DLT till both the breath sounds are equal. And if we see, observe that decreased breath sounds are there in the left side, it means the endobronchial lumen has gone into the right mainstem bronchus. This is very common because of the vertical arrangement of the right mainstem bronchus to the trachea. So we'll have to withdraw the DLT to mid trachea and do that maneuver I had mentioned before till the breath sounds are equal. And then we ventilate as a part of step 2 with the tracheal lumen clamped. Now, if there is decreased breath sounds to the right, then we can go ahead. This step is cleared. But if there are equal breath sounds on both the sides, it means both the lumens are in the trachea. So we'll have to advance the DLT until breath sounds are decreased to the right lung. And if there are decreased breath sounds to left, the endobronchial lumen is in the right mainstem bronchus, and obviously we'll have to withdraw, do the maneuver till their breath sounds are equal. And in the step 3, to confirm the proper isolation, we ventilate with bronchial lumen clamped. So if there is decreased breath sounds to the left, we have achieved the lung isolation successfully and we can proceed with the surgery. However, if there are equal breath sounds, this means both the lumens are in the trachea. We have to repeat step 2. And if there are decreased breath sounds to the right, the endobronchial and endotracheal lumens are in the left mainstem bronchus. Then we'll have to withdraw it till the air entry is equal as per the step 1. Now, positioning a right DLT is very tricky. And this slide may also look very congested, but I'll try to ease out this trick and simplify the slide. So like for a left DLT, once the endobronchial tip of right DLT has passed through the vocal cords under direct laryngoscopy or video laryngoscopy, stellate is removed. The DLT is rotated 90 degrees to the right and slightly advanced. So till here, except for the side, it is rotated, everything is same. However, as per the recommendations, any further advancement is to be done bronchoscopic guided. So the bronchoscope is passed through the bronchial lumen to inspect patient's right bronchial tree anatomy and to ensure whether a proper right DLT placement will be feasible. This is because of anatomic variations that we have to inspect the bronchial tree anatomy. In 3% of the patients, the right upper lobe bronchus originates at the level of carina or even within trachea. And obviously in such cases, the ideal positioning of DLT is not at all possible. After that, the right DLT is advanced into right mainstem bronchus under direct bronchoscopic visualization. So as you can see, this is the initial view. When the bronchial lumen is in the trachea itself, we have a fiber optic bronchoscope at the tip of the bronchial lumen. We can see carina. And we can identify this because the membranous trachea can be seen, the point 1. Then there is carinal bifurcation from 12 to 6 o'clock, which is very sharp. And we can see the left and the right mainstem bronchus, and no further bifurcations are in sight. So we can confirm that this is carina. And next is we enter the right mainstem bronchus. We try to go there, and we can see that right mainstem bronchus is short. This line is indicative around 2.5 centimeter. Then at 3 to 4 o'clock, we can see the opening for the right upper lobe bronchus. And this is where we have to align the slot of the bronchial cuff. And further down, we can see the right bronchus intermedius, which will give away the bronchial openings for the middle and lower lobe. So when we enter the right upper lobe, we can see this characteristic bronchial trifurcation into the 3 segments of right upper lobe, the anterior, posterior, and apical segments. So this confirms that we are in the right upper lobe bronchus. And when we go further, right bronchus intermedius, we can see the openings of right medial lobe and right lower lobe. So we place our DLT and guided by the bronchoscope such that it is optimally aligned with the right upper lobe bronchus. So this optimal alignment will occur in 2 dimensions, requiring insertion to both the appropriate depth and optimal rotation of the DLT, because this is only on one, the slot is only on one side. So we are confirmed with this alignment. Then we insert the fiber optic bronchoscope through the tracheal lumen, and we can see the carina, the left main bronchus is patent, and tube can be seen entering the right main bronchus. As per the auscultation is concerned, it is very similar to the left DLT. The same process is there. Now, how the selection of left versus right DLT is made? This is a very common question which is asked during the table viva. So for the left DLT, it is the most commonly selected because of its easier positioning as compared to the right DLT. And there is a larger margin of for error compared with right DLT due to longer length of the left mainstem bronchus, around 4.5 to 5 centimeters. For the right DLT, positioning of the tube requires precision in aligning the side ventilation orifice with the takeoff of the right upper lobe bronchus, and complications due to malpositioning are very common. So right DLT is specifically indicated in distorted anatomy of entrance of left mainstem bronchus due to external or intraluminal left bronchial compression. Site of surgery that involves a left mainstem bronchus is also a specific indication of right DLT. Now the complications of DLT, so the difficulty with insertion and positioning, this is there. Any difficulty post can lead to tube rupture of any of the cuffs, and especially with any difficult patient already has an anticipated difficult airway, it will be difficult to put this. Then tube malpositions are a common cause which can lead to inadequate surgical exposure and hypoxemia. Then trauma, which I'll be discussing further in the next slide. Then all the complications which are related to the tubes, which are endotracheal or endobronchial, like injury to the mucosa and all that are same with the DLTs. Any injuries caused by the cuff, overinflation of the cuff, and then there might be surgical complications like taking of the bronchial cuff or tube in the surgical closure may lead to difficult extubation, maybe while we are extubating or when we are exchanging the DLT for a single lumen tube for post-op mechanical ventilation. Now, as per the airway trauma associated with DLT, the incidence of airway rupture with DLT is quite less. It is less than 0.2%. But if it occurs, mortality is quite high, reaching up to 42% as reported. Potential risk factors or causes for airway trauma are direct trauma caused due to insertion with increased force, choosing a large tube, and the tube is advanced with a stillet. Cuff overinflation, which can be rapid inflation, large inflation volumes, or distension caused due to use of nitrous oxide, or any other pre-existing airway pathology which predisposes the patient to airway trauma with DLT. So we can prevent this by routinely reviewing the chest imaging for airway abnormalities, remove the DLT stillet after it passes the vocal cord, use FOB guidance if resistance is encountered during blind advancement. And if bronchial cuff volume more than 3 ml is needed, consider choosing a larger size DLT and avoid use of nitrous oxide. Now you may be asked about alternatives to DLT to achieve the intended outcome of one lung ventilation. So bronchial blockers are there, single lumen tubes are there which can be inserted into the bronchial tree, into the left or right mainstem bronchus. Then there are integrated single lumen tubes with bronchial blockers. Embolectomy catheters, Fogarty catheters have been used. So I'll not be obviously discussing about these alternatives in details, but you may be asked about these. Now, another question which can come up is why to choose DLT over bronchial blockers? What are the specific advantages of each over the other? So with the DLT, these are faster to insert and easy to position, and lung isolation can be established. It is less likely to become malpositioned when compared to bronchial blockers. The ability to ventilate, suction, or employ FOB is maintained for pathologic lung. It is preferred for patients with copious or thick secretions because the narrow suction channel of bronchial blocker may not allow suctioning of thick secretions. While with bronchial blockers, they are more likely to require repositioning facilitated by FOB. However, there is lower incidence of sore throat, hoarseness, and airway injury. These are preferred devices for anticipated difficult airway and for patients who already have a tracheostomy or abnormal tracheobronchial anatomy. And they also may be advantages to achieve selective collapse of part of the single lung lobe. So selective collapse is possible with this rather than collapsing an entire lung. So I have not gone into details of physiology of one lung ventilation, the hazards of that, and how to tackle hypoxemia associated with that, deflating a lung using CPAP. because that's a very long topic and we can discuss it whole evening and it will be less. So these are some good reads and also my references for this discussion. And all the best to all of you for exams. Thank you.
Thank you, Dr. Swati, for a very comprehensive presentation, I must say, which covered all the aspects, right from the relevant anatomy, the DLT per se, its technique of insertion, complications, and various types of DLT and the blockers. Thank you very much.
Thank you.
Well, it's the time now that we move on to the next topic on bispectral index, or BIS, and none other than Dr. Anju Gupta will be enlightening us on this topic. And I'm sure this is where the budding anesthesiologists are too eager to know that what is this so special about BIS, which has been used to supplement Giddle's classification, which was delivered long time back, decades before, and obviously to reduce the incidence of the intraoperative awareness, we have BIS. And but then yes, that's what Dr. Anju Gupta will be enlightening, that this is one monitor which was introduced way back in 94, almost now 28-30 years back, but it is not without controversy. And there are things which Dr. Anju Gupta will be enlightening you about this particular topic. So we have Dr. Anju Gupta, who who's a professor at All India Institute of Medical Sciences, and she has a very large number of publications, a series of publications to her credit, and a good number of guest lectures have been delivered by Dr. Anju Gupta, and a very dynamic and a very professional, knowledgeable faculty. Dr. Anju Gupta, please, to enlighten us on bispectral index. Thank you, Dr. Anju. Thank you. Dr. Anju, yeah.
Sir, am I audible, sir?
Yeah, please. Yes, you are audible. You're audible.
Thank you very much, sir, for your kind words. And my deepest regards to all my teachers who have taught me and made me to what I am today. And also, I would like to thank the team RSACP for giving me this opportunity to deliver this talk. So BIS monitoring, apart from BIS monitoring, I will also be touching upon briefly on why, when the awareness under anesthesia happens, and some brief amount of history of and classification of the methods used to detect awareness under anesthesia. I think these all are needed for PG students. So why and when awareness under anesthesia happens? So let's understand what is awareness under anesthesia and why it happens. So depth of anesthesia is basically a continuum of CNS depression and decreased responsiveness to stimulation, which is induced and reversible. And why it is needed to be measured, because too deep a plane of anesthesia can lead to serious depression with hemodynamic instability, and it can prolong the awakening time, thereby increasing the cost of anesthesia and the PACU time. So, and what about if the plane is maintained too superficial or too light, then the patient will suffer from what is known as awareness during surgical procedure, which is very frightening for the patient and can even lead to post-traumatic stress disorders. And it has been responsible for a lot of lawsuits, especially in foreign countries. So what are the most vulnerable periods where the awareness under anesthesia happens? It is basically the time periods when there is a lapse in the adequate depth of anesthesia. That is basically at the time of securing the airway, when there is delay or multiple attempts, or we take longer than usual to secure the airway, it can lead to dissipation of the hypnotic agent effect. And that can lead to, that is a very common cause of awareness in cases of difficult airway. Then when the nociceptive surgical stimulus is applied first, that may be the time when the patient can perceive it because of the inadequate analgesia at that time. And near the end of the surgery, many of us do a little bit haste in bringing the patient to consciousness, and then the patient can perceive the tube, and that is another common cause. So those who have seen this, this awareness is that the gravity of the awareness, the problem of awareness is such that it prompted the Hollywood makers to make this movie known as Awake. So just imagine the awareness of the lay people regarding this problem under anesthesia. So awareness of awareness is very high. So intraoperative awareness, the overall incidence of intraoperative awareness is said to be about 0.2 to 3%, but the incidence is as high as more than 40% in patients with cardiac surgery, cesarean section, multiple trauma, hemodynamic unstable patients, because we intend to achieve deliberate lighter planes to maintain hemodynamics, and preventing fetal impairment is another cause for cesarean sections. But everyone should know this, that it is the third commonest cause of litigation, and the amount of litigation is increasing day by day because other causes are reducing, and this cause is still persistent. So this is an important cause of litigation in UK, and up to 20% of claims are because of awareness. What are the consequences? Why? What is the importance of knowing the reason to prevent awareness under anesthesia? What is the importance of this? Is because the most common complaints from patients who suffered from awareness was auditory perception, the loss of motor power. These were the most common complaints. While 62% patients reported no pain, severe pain was still reported in 17%. And patients who reported the inability to move and feelings such as helplessness, anxiety, and panic were significantly related to the persistence of late psychological symptoms, and post-traumatic stress disorder was seen in 20 to 30% of these cases. Which I thought would be important for the PG. It is frequently asked that what is explicit memory and what is implicit memory. Explicit memory is basically conscious recollection of previous experiences, basically during anesthesia, if you're talking about intraoperative awareness. So basically it is a conscious perception or recollection of the events, and it is the direct memory test. Implicit memory is basically when the patient denies recall, but at subconscious level, the patient has the memory and that affects the behavior. Amnesia can be interrogated amnesia when the drug with the amnestic property is administered before the induction of anesthesia to prevent awareness or development of memory of the events during the anesthesia. Whereas retrograde amnesia is intended when the drug is given after the event and which may have been associated with the intraoperative consciousness. If the patient suffers from any such event, then we might like to administer some such kind of anesthetic. But it is difficult to achieve retrograde amnesia. Coming to a little bit of history on awareness of anesthesia, the first successful public demonstration of anesthesia by August Bayer was also the first case of awareness under anesthesia, because the patient, that is the Edward Gilbert Abbott, he later on stated that he was aware under the anesthesia. So it is an interesting event to know. So many people in the past, in the historical era, have tried to, quantify the depth of anesthesia. Among them, the earliest one was the John Snow, who described 5 degrees of narcotism under ether anesthesia. Later, they were refined by Goodell into the very well-known 4 stages of anesthesia as we know it today. And then Artusio, it's further subdivided the stage 1 into further 3 stages. So Artisio expanded the Goodell stage 1 into 3 further planes: no amnesia and analgesia, total amnesia, partial analgesia, and complete amnesia analgesia. One important classification by Woodbridge is important to know. He described 4 components, which are basically the 4 components of anesthesia which we should be targeting at. That is the sensory blockade of afferent impulses, motor blockade of efferent impulses, then reflex blockade of all the systems, respiratory, CVS, and GIT, and mental block, or which is known as unconsciousness. So now it is important to know that what are the risk factors for awareness, so that we can specifically target this population specially and prevent awareness under anesthesia. So what are the risk factors? What are the patient risk factors? The patient risk factor, one important risk factor is the history of awareness, previous history of awareness under anesthesia, because there is some genetic resistance to anesthetics, which can lead to incidence of awareness under usual doses of anesthetics. Then females, obese patients, those with higher ASA physical status, Those with impaired cardiovascular status, difficult intubation, end-stage lung disease, heavy alcohol use, or chronic benzodiazepine or opioid usage is associated with high risk of intraoperative awareness. Anesthetic risk factor include any equipment malfunction, insufficient dosage of anesthetics, avoidance of opioid during induction, and TIVA. Because TIVA, there can be IV line disconnection, there can be malfunction of the pump, there can be cannula extravasation. So we have to be very careful about these things. And also there is an inter-individual variation in dosing requirements. So now coming to what are the various techniques to monitor the depth of anesthesia. I will not go into the detail of all of these because I have to cover the BIS in detail. So, but we have some clinical and conventional monitoring technique, out of which many are of historical importance only. And then we have end-tidal anesthetic concentration, which is a very, very important and routinely used monitor. And then we have evoked or spontaneous brain electrical activity monitors, which include a whole array of these monitors, beginning from EEG and then patient entropy, BIS, narcotrend, patient safety index. These all are the electrical activity monitors. Coming to the clinical and conventional monitoring parameters, the clinical signs, everyone beginning from a high-end setup to a lowest possible setup, everyone definitely monitors and looks for these signs to titrate the anesthesia. This is the one constantly being monitored, but it is not very reliable parameter to monitor for intraoperative awareness. PRST, as it stands for pressure, that is systolic blood pressure, heart rate, sweating, or tears. These all signify the activation of the sympathetic nervous system in relation to the awareness. Then, but there can be a whole lot of factors which can lead to sympathetic stimulation under anesthesia. Then there are other factors, that is loss of reflexes, then apnea, then atonia. Then there is a thing which is rarely used now, the isolated forearm technique. The tourniquet cuts off the supply of neuromuscular blocking agent to one forearm, and the movement is checked either spontaneously or on command. Then there are some objective measures which are generally not used routinely. That is skin conductance, which is a quantification of the sign of sweat production, which is initially low, but it increases. The skin conductance increases as the depth increases. But it is also influenced by a lot of factors. Then there is surface electromyograms, which is the most frequently used muscle is the frontalis muscle, and FAEMG is observed to fall during anesthesia, and it rises with recovery. Then lower esophageal contractility. It can be either spontaneous or provoked contractions, which reduce in latency and amplitude during the general anesthesia. Then coming to one important monitor, that is end-tidal inhalational anesthetic agent monitoring. That is, it has been said to be at par in preventing the awareness. It is gold standard for dosing the inhalational anesthetic agents, but there are some limitations. MAC awake varies for inhalational agent, and inhalational agent are said to produce immobility by action through spinal cord. Hence, it cannot be a direct measure to predict the brain state in anesthetized patients. And we all should remember that the MAC incision, as we all know and we quantify, it is different from MAC intubation and MAC bar, which are much higher. And altered physiological states may change the requirement of inhalational anesthetic agent. And also, it is an indirect measure, as it is based on some presumptions. So the pitfall is that it prevents the anesthetic awareness, but there is a risk of overdosage because it is an indirect measure. And it cannot be used, obviously, with the TIVA. So what are the basic principles of brain electrical activity monitoring? It appears to be slightly complex for PG students, but we need to understand some basic small principles which apply to all electrical activity monitors. The surface recording of summed electrical potential which arise from cerebral cortex is the EEG, which have amplitude and frequency. But the raw EEG is very complex and it is difficult to interpret in real time while we are giving the anesthesia. So it is not practical to be used in operation theater. So processed EEG is the one which is used, and it is the basis for all depth of anesthesia monitoring. The time domain analysis is plotting of voltage changes over time. Burst suppression ratio is the proportion of time of suppressed EEG activity over a period of time. Then frequency domain analysis and bispectral analysis is basically obtained after Fourier transformation of EEG reading. Frequency domain analysis is basically power spectrum analysis, uses power and frequency. Bispectral analysis quantifies the relationship between those components of waveform by comparing the amplitude and phase angle of different waveforms. So basically the raw EEG is transformed into specific frequency by Fourier's transformation. The basic principle basically here is that the EEG activity is recorded from the electrodes placed on the forehead. Then from the raw EEG, analog signal is amplified and converted into a digital domain. Various algorithms are applied to the frequency, amplitude, and latency, and a single number is generated, which is the dimensionless index, which is scaled between 0 to 100. And this number basically signifies the existing state of consciousness of the patient, with a value of 100 signifying a awake state and a value of 0 occurring at the isoelectric EEG. Induction leads to a fast frequency rhythmic waves in a alpha range, that is 8 to 13. And increased depth of anesthesia leads to initial decrease in frequency and increased amplitude, and later deeper levels shows burst suppression and later on a flat EEG. So bispectral index monitor is basically, it uses a proprietary algorithm which processes the single frontal EEG signal and generates the dimensionless number, which provides the measure of the level of consciousness. And it is composed of the combination of time domain, frequency domain, and higher order spectral subparameters. So basically on one single electrode is applied on the frontal area. So how to apply the electrode? This is another important thing to know, because this is what determines the quality of the signal. So there are these, first of all, the first important thing is to wipe the forehead where you are going to apply the electrode. Wipe it clean with a spirit alcohol, and then let it dry before applying this electrode. Then the first electrode is applied at the center of the forehead above the nasal bridge. Then second is applied diagonally over the forehead. Third is applied directly over the eyebrow. And fourth is applied between the outer angle of the eye and the hairline. So there are certain, the BIS monitor, when it is, it shows these certain parameters which are important to know what these stand for. The EMG signal, electromyogram signal, is also being EMG. Most of you would have noticed that there is a EMG reading when you apply the BIS monitor. This is an important reading and we should not disregard it. It depicts the presence of muscle activity, that is in the frontalis muscle. There is a muscle activity, or it can also detect a high frequency artifacts. So when this is present or it is high, then we should interpret the BIS with caution. Similarly, a signal quality index, which may be shown by this graph or numerically. This is also important to indicate the quality of the signal over the past 1 minute. Then there is a suppression ratio, which indicates the percentage of the last minute that the EEG signal was suppressed. And this burst suppression refers to the burst of EEG alternating with the isoelectric EEG. This is the value of the EEG BIS value, which can be between 0 to 100, depending on the patient consciousness. Then there is a trend for BIS, which is displayed over the time. And this will tell you that you have ensured a sufficient level of anesthesia, a stable level of anesthesia throughout the surgery. Then there is a EEG waveform also being displayed in some monitors. So what are the BIS values which are acceptable for anesthesia? Maintaining the BIS index from 45 to 60 during general anesthesia ensures unconsciousness with a hypnotic or opioid anesthetic technique while providing for a rapid emergence. This was shown in a paper in 2000, as early as 2000. So BIS in approaching 90 and above will signify a awake patient. Then moderate sedation, 70 to 80 range, will signify moderate sedation. Then large amplitude, so slow frequency waves will be signify the general anesthesia, that is in the BIS range of 40 to 60. And then deep anesthesia is below 40. And then isoelectric EEG when there is a electrical silence, a straight line. So this will be how the electrode will be applied, and the monitor will be this is what the monitor will be showing. This is the BIS reading, this is the suppression ratio, this is the EMG, and this is the signal quality index. So how we titrate the anesthesia according to the BIS? First of all, we have to decide whether the BIS reading is between 40 to 60. If it is yes, then is the signal reliable? Yes, the signal is reliable. We can continue with the current regimen. If the signal is not reliable, we have to address the reasons, whether the lead is misplayed or electrical interference from other interfering agents like cautery. Then if the BIS is more than 60, that is the anesthesia is inadequate. Then we have to look for the factors, that is a concurrent change in surgical stimulus, which warrants a deepening of the plane, or clinical signs which are showing that the patient needs an increased anesthetic dose, or it may be falsely elevated in the setting of mechanical interference or recent administration of anesthetic agent like ketamine, which are known to increase the BIS. Now, when the BIS is less than 40, that is a very deep plane. It can be a true reading, it can be a false reading. So concurrent change in surgical stimulus or clinical signs like fall in blood pressure, heart rate will warrant a decrease in the anesthetic dose. It may be falsely decreased after the administration of paralytic agent. And we can consider acute decreases in the blood pressure, temperature, and blood glucose in the absence of acute surgical change in surgical stimulus and anesthetic dose, which can lead to a false decrease in BIS. So what are the limitations of BIS? It is not free from errors. It has a lot of limitation. The BIS, the range of BIS value over which the patient sleeps varies inter and individually, and it is a very wide range. And any stimulus causing cortical arousal may lead to an increase in BIS, as I have already discussed, unlike stimulus such as adrenaline infiltration. EMG activity may falsely elevate BIS. Then algorithm is not applicable to some anesthetic like ketamine, nitrous oxide, and some other agents like xenon. Then paradoxical increase in BIS at deep isoflurane has been seen as blind spots in the algorithm. Then ischemia, hypothermia, senile dementia, these decrease the reliability of the BIS. Profound hypotension, hypothermia, hypoglycemia, brain state activity, these all have been said to decrease the BIS. Low BIS values are also seen in individuals who have genetically determined low voltage signals. Then these artifacts like EMG activity, artifact from cardiac pacemaker, blood fluid warmer, patient warming devices, these all can interfere. So what are the benefits of BIS other than preventing intraoperative awareness? It has been found to, in many studies, to reduce the recovery times as compared to the clinical monitoring. It has been found to reduce the length of PACU stay by approximately 7 minutes. It decreases the anesthetic consumption, and it has been found to decrease the incidence of PUNB in some studies. Then what is the effect of BIS, some specific drugs on BIS? We should, the PGs, the students may be asked this question regarding specific drugs in their viva or in the exam. So ketamine is a drug which can lead to false readings on BIS. So ketamine acts by NMDA receptor. In smaller doses, it blocks the excitatory glutaminergic inputs and to the inhibitory neurons. And in higher dosage, it blocks the excitatory glutaminergic neurons and leads to unconsciousness. Increased activity of the pyramidal neurons, that is loss of control from inhibitory neurons, leads to high frequency oscillations. And that has been a reason for higher BIS readings with ketamine despite the impending induction. So dexmedetomidine is another drug which has an action on presynaptic alpha-2 receptors, and loss of adrenergic inhibition of the hypothalamic preoptic area leads to activation of GABAergic inputs to the arousal centers. And this inhibition on the arousal centers causes intermittent burst pattern of 9 to 15 hertz oscillations. This slow wave pattern resembles the NREM sleep stage 2. Hence, even light sedation can mimic deep NREM sleep. Nitrous oxide is another drug which in high doses can lead to large slow delta oscillations, which can convert high frequency gamma oscillations in 3 to 12 minutes. Hence, EEG and BIS can be misleading. So what are the changes in BIS with age? It is important to know that there are certain changes in the brain electrical activity and the waves with age, which can lead to a misleading BIS reading. That is, in EEG in 0 to 3 months, only slow zero delta oscillation is seen, and anteriorization and coherence of alpha oscillation is seen only after 1 year of age. Hence, BIS is accurate in children generally over the age of 1 year. Alpha band is characteristic of 18 to 35 years. Senile dementia may be a confounding factor in the interpretation of the BIS value, but there is no definite evidence that BIS guided anesthesia leads to improved outcome in older patients. What are the measures which can prevent awareness during anesthesia? We have to check the machine and vaporizer before each use. We should use end-tidal anesthetic agent monitor with alarm for low concentration. We should redose the hypnotic for repeated intubation attempt. This is one thing which many of us tend to forget. We should be aware of the potential of hypovolemic patient. My one take home would be that you should not titrate the anesthesia based on heart rate and blood pressure and let the patient suffer with awareness. Instead, the patients who are not able to tolerate the anesthetic induced vasodilatation, they should be treated with inotropes or vasopressors rather than lightening the plane. Use of neuromuscular monitoring, and while using the neuromuscular monitoring, we should ensure the hypnosis. In TIVA, while giving TIVA to the patient, we should ensure a patent IV line and we should check the syringe pumps. We should label the drug syringes and always confirm the labeling. And we should consider the use of depth of anesthesia monitoring, at least for patients who are at high risk. So to summarize, this monitor reduces the incidence of intraoperative awareness. It correlates well with the level of responsiveness and provides the excellent prediction of the level of consciousness with propofol, midazolam, isoflurane. It correlates with the hemodynamic response to surgical incision and verbal command during inhalational as well as total intravenous anesthesia. It reduces the cost by saving anesthetic use and reducing the stay in PACU, and it provides a useful guide for titration of the anesthetic agent. And it should ideally be used routinely, but at least definitely in high-risk cases. Thank you very much for your patient listening and giving me this opportunity. Thank you very much. Any questions?
Thank you so
much. Happy to address.
Thanks very much indeed, Dr. Anju, for such an excellent lecture, very comprehensive one, where you nicely describe to BIS or not to BIS. And it is really a wonderful supplement, for everyone, And we, as you know, we'll have questions in the end. All right. And I'm sure those who have some queries regarding BIS, of course, you have so nicely described everything, even touched upon the significance of adding ketamine or nitrous oxide and things, what kind of swing do they take. And but yes, there's nothing without controversy, and that is what BIS also is not without controversy. But even then, yes, it's the best available tool that one can have. So thank you very much indeed. Now I pass on to our honorable chairperson for the next session, Dr. Nishkarsh, please.
Thank you, sir.
Thank you, sir.
So much. Thank you.
I request Dr. Dali to introduce.
Yes. Now it is a time for the last speaker, but not the least. And it is none other than Dr. Nishkarsh Gupta, who is the moderator of this session also. And he'll be speaking on neuromuscular junction monitoring. And this topic, as we know, is not only important from the examination point of view, but clinically also. Day in and day out, we have been dealing with giving and using neuromuscular blocking agent. So right at the time of induction, maintenance, problems at the reversal, recovery. So every time we need the monitoring to give us some help and clue whether we are on the right track or not. And so to speak on this topic, as I said, Dr. Nishkarsh Gupta is there, and he doesn't require much introduction. He is additional professor of onco-anesthesiology at AIIMS, and he has special interest in airway management skills, onco-anesthesia and regional blocks. He has more than 200 publications, and he is 20 chapters in the book. He is associate editor of 5 books, and recently as a chief editor of the South Asian edition of Clinical Anesthesiology by Brash, and he is the chief editor for that, and that edition has been published only 2 days back, that is on the 15th of June, and I congratulate Dr. Nishkarsh for that. And besides this, he is a reviewer for many of the PubMed journals and national journals, and whatever is written and printed on his CV. Besides that, if I have to summarize his CV in one line, and I'll do it in inverted commas, that it is very difficult for me to decide whether Dr. Nishkarsh is much better a doctor or much better an anesthetist or much better a person, inverted commas closed. So I hand it over to Dr. Nishkarsh for the neuromuscular junction monitoring talk.
Thank you very much, sir. Thank you for all the kind words for me. And you have been a great mentor to me and Anju both for all the endeavors we have always done in life. I thank the RSAP for giving me this opportunity. Incidentally, neuromuscular monitoring is an important talk, and it is something which is very important but not often done in our OT setup, despite being being available to us. So this is the outline of my talk. So I'll be discussing about why there is a need for monitoring the neuromuscular junction, then what are the equipments, what is the basic physiology behind this, what are the patterns of nerve stimulation, some of the equipment and sites, and how do we interpret the results. So now coming to the basic question that why monitor? So despite the introduction of a lot of intermediate and shorter acting neuromuscular blocking agents, so all of us know that incidence of incomplete neuromuscular recovery post anesthesia and the recovery phase in the post-op period is about 40%, which is very high. And it is generally defined as a 10/4 ratio of less than 0.9 when until recently now they say 10/4 ratio of 1 with a quantitative neuromuscular monitoring. So even if the 10/4 ratio is less than 1, so the possibility is high. So we have to target a 10/4 ratio of 1. And this is defined as a presence of signs and symptoms of weakness or muscular weakness after administration of neuromuscular blocking agent, even when blockade is reversed in the operating room. So we many times face this scenario that we have given the reversal, the time is there for the reversal, and we find the patient is behaving strange, so they are not responding much, and they feel difficult in breathing. So this is happening because we are not monitoring the junction through objectively, we just are relying on the clinical signs. So why do we actually monitor? So as I earlier told, that residual post-op neuromuscular blockade is a dreaded complication, and these are all the case reports which have and the series which have discussed this problem. And this leads to functional impairment of pharyngeal and upper esophageal muscles, impaired ability to maintain airway, may increase post-operative complications. More importantly, hypoxic ventilatory drive is reduced. So if this is reduced, what will happen is that the remaining neuromuscular blocking agent, what is there in the junction, becomes more potent. So it will become more resistant to reversal. So this adds to the problem. And overall, the length of stay may increase. So clinically, it may be difficult to exclude patients with residual correlation. So the need of monitoring is important. So now, how do we define a monitor? So many times in the table viva, you might find this kind of strange looking equipment. So probably strange because we have not used them. They are mostly there in the setups, but we do not use them routinely. So basically how you can define is that assessment of function of a neuromuscular junction using objective test or a subjective methods. So this is a neuromuscular monitor. So neuromuscular monitor should fulfill two criteria. First, it should deliver a stimulus to a peripheral nerve. Secondly, it should be able to detect, measure, and analyze the evoked muscle contraction or muscle action potential that result from this above stimulation. So both the criteria should be met to label our equipment as a neuromuscular monitor. So the objectives of neuromuscular monitoring include, we have to monitor the onset of the blockade. So we must know when the depth of blockade is maximum so that we can plan the intubation and time it. Because there have been times when we wait for 3 minutes and still we find the patient is bucking and coughing because the onset probably is delayed for various reasons in the patient, and it was not the right time when we had initiated the process. Then to determine the level of muscle relaxation during the surgery, and assess patients' recovery from blockade to minimize the risk of residual paralysis. So now, if you ask me, neuromuscular monitor is essential for practically all surgeries, but yes, for some surgeries, it should not be missed at all, like those patients who are on prolonged infusions of neuromuscular blocking agents or when long-acting drugs are used. When we expect a surgery or anesthesia to be prolonged, when patients are ASA2 and 3, they have borderline respiratory function, they are morbidly obese, they have cardiac arrhythmias, cardiac disease. When if we have an inadequate reversal, it may be very devastating. The margin of safety is not there with the patient, and catastrophe chances are much higher. Then when giving a reversal agent may cause harm, like in cardiac diseases, then patients with liver or renal dysfunction, because all the drugs are metabolized mostly in liver and or kidneys, and so their pharmacokinetics is altered. So the prolonged effect, you need to monitor them more accurately. And we have neuromuscular disorders like myasthenia or Eaton-Lambert syndrome. So those diseases, you have to be very careful, and we have to selectively monitor the neuromuscular junction and give it gradually. Now coming to the clinical tests for neuromuscular recovery, all of us know them. So we have unreliable tests like sustained eye opening, protrusion of the tongue, arm lift to the opposite shoulder. So there are many of them we are using regularly, but they are unreliable. And some of the tests are possibly present. So you may have a vital capacity, or you have a normal tidal volume, we many times see, but TOF ratio is mostly less than 0.4 or 0.6, and which is not acceptable. Some other clinical tests are reliable, but they still cannot exclude a residual neuromuscular blockade, like sustained head lift for 5 seconds, sustained leg lift for 5 seconds, sustained hand grip, sustained tongue depressor test, and maximum inspiratory pressure for 40 to 50 centimeters or more. I'm sure we are not doing most of the reliable tests. And even if we do them, the TOF ratio is at most 0.7 to 0.75. There's still a possibility of a residual or blockade in the patient, and you may end up in a problem in the postoperative period. So now we have to think about monitoring. So monitoring can be qualitative and quantitative. So coming to quantitative monitoring, basically these are monitors which measure the neuromuscular blockade and quantify them and give them numerically. So it will give us 0 to 100%. So it is a real-time monitoring and effective in identifying and reducing the risk associated with a residual block. So something like a TOF ratio. So it will tell us what is the percentage of recovery of the patient from the neuromuscular blockade. Then we have qualitative monitors. So these are devices which provide an electrical stimulus to a peripheral nerve, and they evaluate the response subjectively. So basically, whatever response is occurring, they are visualizing the response or feeling it, and they're making a judgment. So most of them are subjective, so not very accurate in assessing it. And most common nerve pattern all of us use is a train of 4 monitoring. A bit of neuromuscular physiology, because it is important to understand the monitoring part of it. So all of us know that acetylcholine receptor is a post-junctional receptor at the neuromuscular junction, and it has 5 subunits. And for a receptor to be activated, acetylcholine should bind to 2 alpha subunits for depolarization. Succinylcholine choline is like acetylcholine, and it will stimulate the receptors and binds exactly like acetylcholine, and the depolarization occurs. And that's why we initially see some kind of muscle twitching and activity before relaxation occurs. However, if we give a higher dose of succinylcholine, say about more than 4 to 5 milligram, or we give a continuous infusion, or we repeat the doses, you may see a phase 2 block, something like a non-depolarizing block, in which the block is more prolonged, and you do see a fade. I'll come to fade in the subsequent slides. Our non-depolarizing neuromuscular block is a quaternary ammonium compound, which basically has a positively charged sodium or nitrogen atom, and which has affinity to acetylcholine receptors and binds to any one of the 2 receptors on the acetylcholine receptor, one of the 2 subunits. So for succinylcholine, acetylcholine, they have to bind to 2 units. While they can bind to any one of them units, they prevent depolarization and lead to muscle relaxation. So some of the definitions which are commonly used, and you may be asked in the Viva in case you end up picking a neuromuscular monitor or examiners ask you. So they may ask you, what is fade? So fade is something like if a stimulation is prolonged, any kind of stimulation is prolonged to an NMJ, the neuromuscular junction becomes refractory, and it is incapable of releasing sufficient quanta to maintain a depolarization. So if you keep on stimulating a nerve muscle junction, it becomes refractory to further stimulation. So this is called a fade. So it usually occurs in a non-depolarizing muscle blockade following when you monitor using a train of 4 or a DBS. Then there is something called post-tetanic potentiation. So all of us know that whenever calcium nerve is stimulated, so acetylcholine released by stimulatory nerve is proportional to the amount of calcium with ions present. And so if you increase the calcium ions by 2 times, the increase of acetylcholine can be up to 16 times. So it is roughly about 8 times it. So during a tetanic stimulus, what happens is the calcium entering into the nerve with every stimulus tends to accumulate. So whenever we subsequently stimulate the nerve and nerve muscle junction, the acetylcholine release is much more than what is usually released, and so the size of twitch is increased. So this is called the post-tetanic potentiation. It is important when we see the post-tetanic count and those things, which will be coming in subsequent slides. And next is the supramaximal stimulus. This is also important because it is the amount of current which is required to induce depolarization in all the fibers of the nerve bundle. So basically, we know we have a lot of small muscle fibers in the muscle bundle, and they have different refractory periods. So for a good response, we want all the muscle bundles should fire at the same time. So what we do is we gradually increase the current, and when we see the muscle contraction is maximum and it is not increasing beyond a point, then we increase the current 10 to 20%, and so that the skin resistance and other problems which prevent adequate current from reaching the NMJ are reduced. Usually 50 to 60 milliamperes is sufficient as a supramaximal stimulus. Then neuromuscular blockade is divided into intense, deep, and moderate. Intense neuromuscular blockade is basically it occurs within 3 to 6 minutes of intubating dose of non-depolarizing muscle relaxant, and when there is no response to any pattern of nerve stimulation. So whatever kind of stimulation you may do a TOF, DBS, tetanic stimulation, there will be no response at all. And it cannot be antagonized by usual cholinesterase inhibitors like neostigmine. So you may have a Sugamadex, which unfortunately not available in India. So if Sugamadex is there, it may still help, but neostigmine will not do help in reversing the effect. Then this deep neuromuscular blockade suggests there is absence of response to TOF stimulation. So TOF monitor, if attached, it will show 0. But once you do a post-tetanic count, you may have it more than 1. So it is kind of a good surgical block, and deep surgeries can be done. Then moderate to surgical block is basically there is a gradual return of 4 responses to TOF stimulation. So if you have only 1 response, the blockade is as high as 90 to 95%. And if there are 4 responses, it may be as high as 60 to 85%. And we have clinically also seen when we correlate. So once we get TOF ratio as 1, TOF response, single response, you may still have the patient's spontaneous efforts coming. So the timing of drug or reversal to a spontaneous effort of patient is sometimes not accurate, and should be cautious while doing so. Now coming to site of monitoring. So before I come to the specific sites, some specific important things about the site, that the site should be away from the surgical field. It must be accessible to the anesthesia provider. If you are monitoring BP and it is an extremity, then we have to measure it on other extremity. Do not monitor on the same site. If you have an AV shunt in the patient, then there is no contraindication to use this for the specific site for neuromuscular walking monitoring. So in patients with upper motor neuron lesions, a nerve is in affected extremity should not be used. So if we have upper motor neuron and we have right side paralysis, we should avoid this site because it may be falsely resistant to non-depolarizing drugs. If possible, nerve stimulator electrodes should be placed on a different extremity from the pulse oximeter probe. So because pulse oximeter tends to affect the movement, especially if you're monitoring the ulnar nerve and the movement of the thumb. So it is better to put on the other extremity. And whatever site we choose, it should have a motor element. So there should be a single nerve, single muscle kind of association. It should be close to the skin. And whatever response is occurring should be visible or accessible to the monitor. So these are the commonly used site. We usually use this ulnar nerve for monitoring, and we see there are 2 electrodes, and we monitor the movement of the thumb. We can use the posterior tibial nerve and we monitor the grade 2 movement, and we can use the orbicularis or auricula, the facial nerve, and additional sites like diaphragm and larynx can also be used. All the sites are equally good, but usually because of accessibility and ease of use, ulnar nerve is most commonly used in most of the setups, and the results are good. Coming to electrodes, so electrodes can be surface electrodes and needle electrodes. So needle electrodes are not commonly used because you have to go close to the nerve, and the chances of nerve injury are there, and you have to somehow place them onto the skin. And surface electrodes are most commonly used. They have silver chloride in them, and basically they help in transmission of impulses to nerves to the skin. A transcutaneous impedance can be reduced by rubbing the skin, and conducting area of the electrode should be small, because if it is a very large conducting area, you may stimulate a lot of nerves in that area, and which may give you a false reading. So it has to be small, about 7 to 11 millimeters. How do we place the electrode? So the distal electrode is placed 1 centimeter proximal to a point at which the proximal flexion crease of wrist crosses the radial side of tendon to the flexor carpi ulnaris muscle. So this is for the ulnar nerve monitoring. And proximal electrode should preferably be placed so that distance between the centers of two electrodes is 3 to 6. So this is the distance that should be there between the two electrodes. So now coming to the methods of monitoring the responses. So there are various methods. We have mechanomyography, mostly of historical importance because of the bulky thing. We have electromyography, acceleromyography, then we have piezoelectric based neuromuscular monitoring, and a phonomyography. I'll discuss one by one all of them. So we have mechanomyography. You can see the bulky apparatus, and we have to stabilize the thumb and the arm, and basically measures the actual force of muscles to assess the degree of relaxation. The arm is fixed on especially molded cast, so we need a special kind of cast, and the thumb is the isometric tension with a preload of 200 grams and attached to the transducer. We can see there are a lot of specifications and not usually available in our setups, and mostly of historic importance. The advantage of mechanomyography was that it is most accurate. So it is considered gold standard and basically used for research. You may find them in physiology labs in our setups. Disadvantage is it is bulky, expensive, and the problem is that it tends to drift over time and may not return to baseline. So it becomes difficult to actually follow monitoring on this device. Then we have electromyography, which is one of the oldest methods. The monitors consist of motor unit action potential generated after the stimulation of the nerve. So we have 5 electrodes. We have 2 stimulating ones, 2 recording ones, and 1 neutral. So these are the 2 recording ones, 2 stimulating ones. One is here, and then one is a neutral electrode. It underestimates the twitch amplitude and top ratio of the non-depolarizing muscle block. It is more useful to assess depth of block rather than reversibility. So more effective when you are doing it the surgery and you are monitoring it. It is simple. It can be used in all the muscle groups. The disadvantage is it may drift over time, may not return to control levels. It may interfere with other electronic devices like cautery, which is quite common, and does not correlate well with the mechanomyography. Now coming to acceleromyography, this should be probably available in most setups. Most of us, including me, are more familiar with this device. We have used it quite often. Basically, it consists of a small piezoelectric crystal which has transduces the acceleration into electric potential, and this electric potential is then measured here as a top mass. The accuracy basically depends on the mass of accelerographic probe. Advantage, we can see it is not a very bulky setup, easy to apply, calibration is very easy, relatively cheap, it is most accurate, and it has a good correlation with MMG or electromyography, as we have discussed earlier. The disadvantage is that muscles which make less movement, like auricular supply, cannot be monitored using a acceleromyography. Then we have kinomyography. This usually comes with a dragger machine or newer anesthesia machines which have inbuilt neuromuscular monitor. We can see the thumb and index finger are molded in a preformed device which is usually of plastic or rubber, and there is a piezoelastic transducer fixed to the thumb. The ratios are similar to MMG and is a practical and accurate kind of alternative to monitoring NMT. Disadvantage is that it requires a careful hand positioning to avoid artifacts, and a response sometimes can be misleading. Then this is phonomyography. I have not used personally, but yes, this basically works on the principle that low frequency sounds generated by the muscle contraction are detected and recorded using special microphones. Very good agreement is there between MMG for erectile laryngeal muscles and the erector pollicis and the corrugator supercilii. The advantage is it is easy to apply, only 3 things to be applied, non-invasive, and can be applied to practically every muscle. However, the problem is that fixation of microphone sometimes is problematic on a muscle. If you have too much pressure or too less of pressure, then the amplitude of the signal might change. And it is not very commercially available at setups. And so it is more of academic importance as of now in India. Now we discussed how to monitor, then now coming to the most important part, then patterns of nerve stimulation monitoring. So we must know all the patterns. Individually, they may come as short notes, they may be asked in the exam, and they do help us clinically during managing the cases. So we have single twitch, train of 4, tetanic stimulation, post-tetanic count, and a double burst stimulation. I'll discuss one by one all of them. So we have coming to single twitch. Single twitch is a single supramaximal electrical stimuli, which is given to the peripheral motor nerve at frequency ranging from 0.1 Hertz to 1 Hertz. We generally start with a low current and gradually increase till a maximum twitch height is obtained, and we fix the current to 10 to 20% more than what is this. So this is the supramaximal current. So once we use a non-depolarizing muscle relaxant, you will find a fade. So with a non-depolarizing muscle relaxant, we will find a gradual fade. However, since it is a single twitch, it does not indicate about deep paralysis, and sometimes basically used before TOF to ascertain what is a supramaximal stimulus, and in research purposes for dose response studies. For a depolarizing block, they will be all or none, so they will not be fades. Either you get a contraction or you do not get a contraction. Then coming to train of 4. So this is the most commonly used monitoring method for neuromuscular junction. So in train of 4, we give 4 supramaximal stimuli, 1 every 0.5 seconds, and 4 stimuli over 2 seconds. And this is repeated every 10 to 12 seconds. So the depth of block basically is measured by either TOF count. TOF count means how many of them actually responses occur, or the ratio. So if you are, if in a normal person without a muscle relaxant, so once you give 4 stimulus, so we can get 4 responses. So 4 responses will occur. However, once you give a non-depolarizing muscle blockade, gradually you may start seeing the reduced number of responses, and eventually it may be 1 or it may be no response at all. And then the ratio of the 4th response to the first is called the TOF ratio. This is most important thing which is being used to ascertain the recovery in the postoperative period. And nowadays a TOF ratio of 1 is preferred for a adequate recovery. So for a depolarizing block, so what we'll see is there is no fade. So all the responses will be of the same height mostly. So once as soon as we give it, it will be reduced to minimum, and gradually once they come, all the responses will be coming. So this is important because this essentially helps us to differentiate between non-depolarizing block and depolarizing block. The fade usually does not occur in a depolarizing block unless it goes into a phase 2 block, and there are reasons to it. We'll discuss in subsequent slides. TOF is most sensitive monitor than single twitch, and it helps to assess the surgical level of paralysis and time the reversal of non-depolarizing muscle relaxant. However, it is not very sensitive to assess very deep block or adequacy of reversal. So now there's another kind of stimulation that is called the double burst stimulation. So in double burst, we usually give 50 Hertz tetanic stimulation of 20 millisecond apart, separated by 750 milliseconds. So stimulation is of basically 50 Hertz for 20 milliseconds, and there are 2 such bunches, 750 milliseconds apart. And what do we see is we are giving 6 stimulus, and important is we see only 2 responses. So what the monitor does is, so first 3 stimulus are clubbed together to give one response, and other 3 stimulus are clubbed together to give other response. So in a non-paralyzed muscle, the response of DBS 3 and 3 means 3 stimulus, 3 responses is 2 short muscle contractions of equal strength. So we get 2 short contractions of equal strength. So if the muscle is partly paralyzed, the second response will be weaker than the first with the non-depolarizing blockade. So if we get 2 responses, you can attempt a reversal. However, if there is no response, the block is much deeper than TOF 0, and you should it is kind of very deep block and usually may be needed for very intense microsurgeries if needed. Important thing about double burst stimulation is it is measured mechanically. The TOF ratio correlates closely with the ratio of DBS 3/3. So it closely associates with this. However, the absence of fade on DBS does not rule out a residual neuromuscular blockade. So we must be aware. So none of the monitors we are discussing is not foolproof. So it has to be in conjunction with all the other clinical parameters and things to come to a conclusion. Coming to technique stimulation, it is the most sensitive to monitor both residual and deep paralysis. So we can give 50 Hertz or 100 Hertz for 5 seconds. So why 50 and why 100? Because this is the frequency which will stretch the muscles to the maximum possible capacity. So beyond 100, there's no point increasing the stimulus strength. So in normal transmission or depolarizing block, a sustained response will be there with the technique stimulation. However, in the non-depolarizing muscle relaxation is given, the acetylcholine is reduced because of the blockade of the receptor, and so we will see a fade. So during a partial non-depolarizing block, a technique stimulation may lead to a post-technique increase in twitch tension or post-technique facilitation, which we have discussed because of accumulation of acetylcholine due to technique stimulation in the pre-receptor area. So no control or pre-relaxant response is required for technique stimulation. So we do not require a control for this. However, it is a very kind of painful stimulus and practically not acceptable for unanesthetized patient. So please don't use them when patient is not anesthetized. Then coming to the post-technique count, this is another important monitoring this thing. So our technique stimulus of 50 Hertz is there, which is applied, and this is followed by 3 or more seconds later by multiple single twists. So what we do is we give a technique stimulation of 50 Hertz, and then we give multiple single twist stimuli, 1 second apart, 3 seconds later. So what it does is that as the intense block will dissipate, so we start seeing a post-technique count due to facilitation of due to accumulation of acetylcholine, as we discussed earlier. And the number of post-technique twist response we see is directly proportional to the return of the first response of TOF. So basically, if we see a post-technique count of 10, so the TOF ratio of 1 is around the corner. It generally comes within few seconds to a minute. However, if PTC is 0, which is a target in some surgeries like microneurosurgeries, the blockade is very profound, and administration of reversal in this kind of setting is not effective at all. PTC 1 means that twitch of TOF will appear in 20 to 30 minutes. So to some extent, PTC will help us to kind of time the TOF responses, and we can see how we can give the neuromuscular blocking agent. And for deep microsurgeries, neurosurgeries, which we do not want any kind of movement, we target a PTC 0. So now how do we interpret them? So basically, we take a baseline value and we inject a neuromuscular blocking agent during the surgery. Gradually, the block will have an onset. So at the onset, we'll gradually see fade with the non-depolarizing muscle relaxant. We have count of, initially you may have 100% ratio, then we have 4 count, 3, 2, 1, and gradually it will become 0. At TOF count 0 will intubate the patient. If the surgery demands kind of intense immobility, you can target a PTC 0. So you may have to give a relaxant in more frequently to target a PTC 0. And once patient is coming out and you can maintain a kind of very deep block, you can keep monitoring the PTC. So once the PTC is close to 10, we know TOF 1 is is coming. So after TOF 1 comes, from TOF 1 to 3, usually it is good for most of the surgical procedures. And once you want to time the recovery or attempt a reversal, you should actually wait for at least 2, preferably 3 kind of responses, top 3, so that the reversal is effective. All of this kind of discussion we are doing is not valid for Sugamadex, and I'm not discussing specifically Sugamadex because we don't have it. And for Sugamadex, these things mostly are not valid, and it can be given as an emergency reversal in case of a difficult airway. And we will discuss it sometime later. Then for another discussion regarding this, how to time the block. So when we are doing induction, you can do a single twitch with a supramaximal stimulation. Then we use a top wash to time the tracheal intubation. Similarly, for deep and intense blockade, we can use a post technique count and target it depending on the type of surgery we are doing. So target it 0, which is the intense blockade is required. Doing recovery and timing of reversal, a TOF is good. And for recovery room, DBS is considered to be best along with TOF, so we can do it accordingly. Now, a word about phase 1 and phase 2 block. This is quite commonly asked in the exam. So when we give a depolarizing neuromuscular blockade agent like a succinylcholine, so usually in usual doses 0.5 to 1.5 milligram. So patients have a classical depolarizing blockade, and we generally on top will not see any fade, and there is no post-technique facilitation. However, if we give repeated doses of succinylcholine, if we give higher doses up to 5 milligram, or a prolonged infusion is given, or in some patients who are genetically abnormal cholinesterase activity is there, and we end up giving a normal dose. So in such patients, you may see a fade in response to TOF and technique stimulation with post-technique facilitation. So essentially, if you you give a succinylcholine and you end up seeing a prolonged block, you apply a monitor, you may see a fade. So this should give kind of tingles in your mind that probably it is going to a phase 2 block. Whatever may be the reason, it may be genetically determined, which we are caught unawares, or we end up giving higher doses. So because this is important to identify, and the management will differ. So any kind of reversal agent, if you give in phase 2 block, is usually not very effective. So you will have to wait for the patient's metabolism to take care of the drug, and you have to keep the patient ventilated till the patient is recovered. Now, like any other monitoring, there are limitations of neuromuscular monitoring. So you may have the responses despite normal persistence of occupancy. The T4 to T1 ratio is 1 even when 42% receptors are occupied. So ratio may be 1 even the receptors may be occupied. So you have to be very careful. You have to see the clinical context as well. So patients might have weakness, even a ratio is about 0.8 to 9. So nowadays we target a TOF ratio of 1. I still remember when we were medical students, we were students doing MD, it was 0.7 for TOF ratio. When we became SR, it was 0.8 to 0.9. And now mostly it is 1 for TOF ratio for effective kind of recovery. An important thing is adequate recovery does not guarantee ventilatory function or airway protection, because there are a lot of other things which are there. So we need to monitor the patient along with neuromuscular monitoring. It should not be seen in isolation. And hypothermia tends to limit the interpretation responses. So please ensure that the patient is warm and the extremity or the area you are monitoring is kept warm so that responses are appropriate. So some of the exam questions that you may be asked about neuromuscular physiology, the modes of monitoring of neuromuscular transmission, what are the patterns of stimulation, clinical predictors of neuromuscular recovery, and what is the need of neuromuscular monitoring. So this may be come as short note or as a full question, or you may be asked in the Viva exam, during the MD exam, or subsequently wherever you go. So be prepared with them. Thank you very much. And best of luck to all the students for who may be giving exam in times to come. Thank you very much.
Thank you, Dr. Nishkarsh, for nicely explaining the importance of neuromuscular monitoring, various modes and devices available, various nerve stimulation pattern, and its importance not only for the reversibility, but also to assess the depth of neuromuscular blockade also when we need to do very fine surgeries. So as the time is running short, I would like that the as we have decided that there will be discussion and question answer at the end of the session. So I hand over to you, back to you, Dr. Nishkarsh, to conduct that discussion as being the moderator of this session. And there may be many questions from the participants and many experiences to be shared by the senior chairpersons, so we can learn from each other. So back to you, Dr. Nishkarsh.
Thank you, sir. So we have about 2 questions in the chat box. One is for Dr. Indra. So one of the students has asked that how many days we can keep the central line in place?
Yes, good evening, sir. Sorry for the glitch which happened earlier. So all the catheters which I've described in my PPT, they are polyurethane catheters. So they are recommended not beyond 7 days, that is within a week we should change the catheter. But in some circumstances, like the patient is having coagulopathy or cannulation was difficult, landmarks were difficult to obtain. So in that case, we can extend maximum 10 to 14 days. And the special types of catheters like the heparin bonded, antibiotic coated and antimicrobial coated catheters, and the silver impregnated catheters. These are for short-term use only. That is short-term, again, there are 2 schools of thought. That is, one school is short-term is maximum up to a period of 6 weeks. And another says up to 3 months, is in prolonged ICU admission patients. So all these catheters also, they should not be used beyond the period of 6 weeks. That is what's recommended.
Thank you, Dr. Indra. Sir,
thank you, sir.
Our esteemed chairperson, sir, ma'am and sir, do you want to add something on this?
Hello. Yeah.
Yes, sir. Yes, sir.
Well, wonderful talks and wonderful speakers, Dr. Nishkarsh. I think it has been a wonderful session, and nothing much to add, but all that I realized was that started with 160 or 170 participants in the beginning.
Yes.
And obviously now it has come down to probably 100 or 98, whatever it is, but
78,
all throughout it was maintained. Also, it was maintained at that particular number. Only thing which I would like to add upon, Dr. Anju is there, and even for others, I think she did talk about the effect of hypothermia, especially on BIS monitoring, which is very important. Yes, she talked about that. And BIS, no doubt, the bispectral index value goes down by almost 1.12 units for each degree reduction in the body temperature. And especially this thing they have seen during the cardiopulmonary bypass. So that's important that to note the effect of hypothermia on bispectral index scoring. That's one. And I'm sure she did talk about patients with neurological impairment. Again, BIS values are on the lower side. So those kind of things are there. And right at the beginning, the students must realize, and I'm sure they are going to talk about it, that, and she did talk about it, is that, the intraoperative awareness with explicit recall, the incidence, even if it is just around 2 per 1,000 patients who have been anesthetized, still it is a significant value, and you can't ignore it. So that is something which I think we must keep it in mind, that even if we may call this number as a raw number, and even if we say that the EMG activity of the frontalis is measured mainly by the lead 4, as you put it on the forehead. So, but this is something which is quite interesting, and one of the most studied monitor, no doubt, and it has been, as she said, positive cost benefit ratio, no doubt, and helps in the minimizing the time to extubation, and wonderful monitor. And I think she did talk about at BIS in great detail, definitely. Thank you so much, Dr. Nishkarsh.
Nishkarsh.
Yes, ma'am.
Thank you very much for all the excellent lectures. They were very well spoken. And the only thing I want to add is I'm not going to be talking about each and every topic, but in general for the students to remember that, yes, you have to see what you are learning. So many places may not be having neuromuscular monitoring. So make it a point that you see these things. You would be seeing an ambu bag, you would be seeing a central venous line, but BIS, as was so well covered, you must make sure that you see a BIS somewhere. And you'll come to know which places have a BIS. Take out a day, your HODs can talk to each other and they will allow you. These are a few things. And for the examination point of view, what I want to just tell is that when it comes on the Viva table, we do not ask you the hi-fi questions and the rare things, but the basics you have to remember. So as was covered in all the lectures, the basics of AMBU, the basics of anesthesia machine, there you cannot falter. And they have a table of anesthesia machine. So those things you must know, the basics. Examiners are very fond of the basic anesthesia machine, and then they go on to the high end. So these are a few things what I want to say, because there were so many things spoken by the teachers, and I'm sure you've learned a lot. But remember, we ask you simple things. You have to pass the simple things, and for that A+, we go on to the very high end things. Am I right, Ashok?
Yeah, absolutely,
Yes,
absolutely correct.
Dr. Jaspreet,
And otherwise,
I fully agree.
so well covered.
May I
Yes,
add
Dr.
something
Tally?
in continuation to what Dr. Jashri has said, that as an examiner and interviewer, there are a few experiences which we share, and I start from where Dr. Jashri has ended, that it is the basic things which many of the examiners like us are fond of, and the candidate should know it also, and then we go for the hi-fi things. And when the basics are not answered, when simple questions are not answered, not only by one candidate, by the whole batch, then it becomes a little anecdote. So if you allow, I can share two or couple of anecdotes in my tenure. And simple one I start with, it was regarding the ambu bag. Manpreet has very nicely illustrated the functioning of all and all this. So when I found that many of the candidates are not answering well about the number of valves in the ambu assembly, if it is used with reservoir and without reservoir, then I thought, let me try this question in the UPSC also. So it was asked in the interview of the assistant professor, and as my habit, I give 2-3 minutes exercise that you teach on a particular aspect of a topic, which is an easier topic given, so that I only want to assess the teaching skill. As a PG, they are getting teaching experience also. So to my surprise, most of them were not able to tell how many walls are there in this ambu assembly, what to talk of, what is the function of each and every wall. Coming to CVP, many of the hi-fi things, double lumen, triple lumen, the candidate may know. In one of the exams, it was a DNB exam in one of the center, whole of the batch couldn't tell me what is a central vein. What is a central vein? When it becomes central. So it was so simple that if I gave him a hint that how will you assess the placement of CVP, then the candidates could say it is moving with respiration. But when I asked him what is a central vein, he couldn't say that the tip should be in the intrathoracic portion of the vein. Like IVC, it has to be above the level of diaphragm. Come to the machine. I remember an MD exam in Northern India. The whole batch of MD students, when I was on the table for the anesthesia machine, I told them to start the oxygen flow. The oxygen cylinder was not there, it was brought. The technician fitted the cylinder immediately on the machine, although I wanted the candidate to fit it. None of the candidate knew how to open oxygen cylinder. Dr. Geeta has very rightly emphasized the importance of oxygen cylinder, because that's the first thing. The machine starts from there, cracking the cylinder, to install the cylinder, how to open it, because it is something like that. We know everything about the adrenaline, but we don't know how to open the ampule of an adrenaline and fill it in the syringe. And so what is the use of knowing the adrenaline if we cannot start the oxygen flow? So these are very basic things that sometimes in many of the teaching institutions we miss to ask to our students, and then they fare quite badly in the exams. So many things we presume that the student will be knowing, and we should include in our teaching curriculum that we have to ask repeatedly about these basic things. So few of the instances I remember, that is why I shared. These are very simple things, but the embarrassment on the face of the internal examiner was more than visible when none of their students were able to open the oxygen cylinder. This is a real thing I'm talking, not hypothetical things. So that is what I wanted to share from my experience side. And thank you very much for including me in this.
Yeah, thank you, Dr. Dali. If I can add one thing more, you are absolutely correct. You know, in one of the exam, Dr. Dali, I did ask, whilst Dr. Jayashree was talking about something very basic. What Nishka talked about is what are the manifestations of the residual neuromuscular blockade? And, the student was not able to answer. He could mention that, yeah, the incidence is around 20 to 40%, whatever it is. And then the next student, when, I asked the same question, there was remarkable difference, because he was able to tell me the pharyngeal dysfunction. He was able to tell me the risk of aspiration and all that, pneumonia and all that, and the need for tracheal reintubation and those kind of things, and a longer stay in the post anesthesia care unit. So you can see the remarkable difference, and this is a very basic question, that what are the manifestations of residual neuromuscular block? I'll give you another example where what Nishkash was talking about, because he very rightly started with the TOF ratio 0.7, 0.75, 0.9 and all that. Then in one of the examination, the student was so bright that he even mentioned that, that Sugamadex at particular dosage of, I don't know, it was 0.222 milligram per kg, and a neostigmine around 35 microgram per kg, whatever it is, effectively and, very comparably reverses the neuromuscular blockade, right? A shallow neuromuscular blockade, I mean, at a TOF ratio of 0.5, just in 2 minutes. Then he added, this particular student, that was almost 4 or 5 years back, when he had added another drug in addition to Sugamadex, that was cannabidiol. Cannabidiol was actually, it remained always an experimental one on rats, but because the work was going on around 2015, 16, 17, and there were publications on cannabidiol. So I was really impressed, that what Dr. Jayashree was talking about, giving A+, that in addition to all that, he even completed the list with cannabidiol. So absolutely correct. Basics will always remain basics, and whatever additional they say will always add to their achievements, definitely.
Thank you, sir.
Thank
Dr. Manisha, ma'am, what's the wisdom for students, ma'am?
Well, I think my seniors have already given very, very good, suggestions and advices. But yes, I also feel that we are always busy reading the theory of any instrument. We open our books and, cram the indications, contraindications. Well, the examiner is always interested in knowing whether you have clinically utilized them, the clinical concepts revolving around them. I still remember a few of the very favorite questions of Dali sir. For example, a thing as simple as an ambu bag. Yes, I can never forget his question, number of valves. So I was expecting that he would be asking this question. Then questions like, can you give 100% oxygen through ambu bag? Can you give anesthesia using your ambu bag? So this is food for thought. So if you are able to answer such questions, that it shows that you know the real concept, the clinical applicability of various gadgets. That is what is more important and make anesthesia more and more interesting. So don't just concentrate on knowing, the theory, but you should concentrate besides that on the clinical applicability of various concepts and things. Yes. Thank you.
Thank you, ma'am.
Thank you, Dr. Manisha, for remembering those 16 or 18 years old memories in the OT, what we have been deciding about ambu bag.
Thank you, sir. So there's one more question in the chat box I just spotted. So somebody asked regarding awareness during cesarean section. Dr. Anju?
Yeah. Thank you very much for the question. Am I audible?
Yes, you're audible.
Yes.
Yeah, okay.
Yes, sir.
My video is not working, but anyways. So awareness during cesarean section is an important concern, and it is a very common thing. The main reason being that we do not want the fetus to be harmed by the anesthetic agents, and that is the main concern. And most of the anesthetists would avoid opioids prior to the delivery of the fetus. But this practice has been questioned recently because of the availability of short-acting opioid agents like remifentanil, though it is not available in India. Another thing is that a MAC of 0.7, if it is maintained at a level of 0.7, it is said to achieve a BIS of 60 in most of the cases. So that is one thing. And another thing, which is that nitrous oxide is a very useful adjunct. And it has been said that concentration of more than 33% of oxygen is not required in most of the cases. So if we can give this much of 66% of nitrous oxide, and if we can give small amount of inhalational agent, then definitely we will be able to prevent the awareness. And obviously we'll need to titrate the anesthesia by using BIS and clinical science. If we use these things, if we use these precautions, and especially in cases where there is a high risk of awareness like obesity, difficult airway. So these kind of cases, we need to prevent awareness proactively, and we need to use these adjuncts. And we should not totally avoid anesthesia before the delivery of the patient. So that is important. If we are using neuromuscular relaxing agent, then we should maintain anesthesia by these techniques. I hope
so. Yeah, that's great. So if I can add something, Dr. Nishkarsh, over here, Dr. Anju. Yeah,
yes, sir. Yes,
that's
sir.
Wonderful. Only thing, again, some of the examinations held and the students, how they quoted, when we asked about BIS, one of the students said that reliance on BIS technology provides a false sense of security about the reduction in the risk of awareness. Though he was not wrong, you see. That's what I'm saying. But his reply was like that because things will, many things will remain controversial. There's no doubt. So that's one aspect. And another student, where when it was asked about the anesthetic awareness with or without explicit recall, that, the incidence coming around 2 per 1,000. And he even added that this particular incidence of 2 per 1,000 is using modified Bryce interview. So imagine a student mentioning using modified Bryce interview, you're getting this much incidence. That was really great. But then he also added that there is no gold standard for identifying awareness as yet, as of today. So I think you will get variety of answers from students, and some of them are really bright, some of them are really bright. Yeah. Thank you, Dr. Anju. Thank you.
Thank you, sir. Thank you for your valuable inputs. So we should look at the holistic picture and not just treat the figures.
Exactly,
so,
exactly.
This is not totally reliable for preventing awareness.
Yeah, that's right. That's right. Absolutely.
In fact, the ASA monitoring guidelines, the first more and foremost is vigilant anesthetic. So that is no replacement at all. And that should always be there. Indrani ma'am, you want to add some words of wisdom to the students?
Yeah. Okay. I think all our seniors have said it all. And keep it simple. I think when an instrument is given to you in your hand, first of all, just describe that instrument very well, and then when the examiner starts asking you the clinical questions related to that instrument, that is when then you have to talk more about the clinical aspects. But initially, when the instrument is being given to you, you're supposed to talk about that instrument first. So, and I think the first, you are given only that many number of minutes, 2 minutes, 3 minutes, or 5 minutes. So in that, how much you can pack your knowledge and tell tell the examiner all that you know is also very important. And sound confident. You have studied for 3 years. And actually speaking, you have gone through Miller, you have gone through Dosh, you have gone through everything. And examiners have not, gone through Miller at, very recently. So it is you who are supposed to have more confident. You have a halo around your head because you have all the knowledge around you. So sound confident. You have to sound that confidence. You have to show that confidence. Then the examiner also knows, okay, here is a candidate who has not only used this equipment, but also knows this equipment. So I think that is also equally important. I mean, having knowledge is one and presenting it is another. So we have had certain students who are who have the knowledge but do not know how to express it. I mean, it's so unfortunate. So we have to ask the internal examiner, how is the student? So that is another thing where the training is very important. We have to ask, every student has to be trained on that aspect also.
May I add a word on this, Dr. Indrani?
Yes,
May
sir.
I add I have something to add, that it is not only the training of the students, but training of the examiners is also very important. Because if we see the examination pattern, in the table viva, if a candidate has to pass on 4 tables, 10 minutes on each table or 7, 8, there, if we give a particular equipment and he starts describing, maybe we will be able to ask only about 1 equipment, and there are about 30-40 equipments lying, and every examiner wants that he should give a trial for 2-3 equipments at least. So what we have during our experience, what I found that whatever equipment he picks or we hand it over, we have a structured some question in our mind, that it should be very specific question, like indication of this, or the contraindication of this, or tell me the uses of this, or tell me the how will you insert this. So we should have a specific question, so that he doesn't have to, because candidate is at a nervous position. If he start describing an LMA for a speaker like this, it will take 20 minutes. So if we expect the equipment to be described by the student, it will take a lot of time, and we may lose patience also.
No,
and we'll
many
not be able
times
to actually assess what we want to assess.
Right.
So
many times the equipment is handed over to them.
We should have a specific question in the mind, that if he picks up this equipment, these are the 2 or 3 questions to be asked, and let us assess that. Here, a slight difference was there in my mind, and I wanted to share this.
Right. For example,
specifically for DNP exam, when there is no internal examiner, we cannot ask the internal examiner. We have to assess ourselves. So that is why the training of the examiners is also important. We should have a little uniform system of examination and assessment also. We should not only blame the candidates. Sometimes we have to introspect ourselves also.
Very true, sir. Absolutely. For example, there are many times, when the examiner is actually too tired and hands over an extra equipment to the student. For example, a double lumen tube. So when they give a double lumen tube, you are supposed to actually describe the double lumen tube when it is handed over to you. So if you want to ask a specific questions, how will you confirm the position? Or, what is the physiology of one lung anesthesia? What are the indications, contraindications? What are the, things like that. So then you can go on specifics. But if a specific question is not being asked, then it automatically means you're supposed to describe it.
Thank you, ma'am. Thank you, sir. Dr. Naveen, you want to add some words of wisdom to the talk? Dr. Vishal?
I've been carefully listening to all the teachers and the lectures, nice deliberations, but I feel it's already 9:30.
Yes, sir.
And we started somewhere around 6 o'clock.
Yes, sir.
So it's better to call a day. Thank you to all the esteemed chairpersons, the teachers, the faculty members who gave nice talks. And it will be ensured that next time our half-day CME becomes a webinar only. Thank you very much. Long live RSACP.
Thank you, sir. Now I invite.
Thank you very much. Thank you very much.
Thank you so much.
Thank you so much.
Dr. Rakesh,
Thank you so much. Thanks a lot to all of you.
Thank you.
Thank you, everybody. Thank you so much for joining.
Thank you.
So long live RSACP.
Thank you.
Thank you, sir. Thank you, everyone.